Well, hello everyone. Very warm welcome to all of you guys in the discussion of physiology, where we will be discussing about the all high yielding important topics that has been asked frequently in your FMG examinations in the last 5 years. What I've done, I've gone through all the Neet PG and FMG PYQs that has been asked previously, and I have just segregated the important things which has been repeated multiple times, right? So those important concepts, those important topics we are going to learn so that we are not going to make any mistakes in the examination. And this is the last minute revision that you should be doing along with me. We will be making it very crisp and concise, and I would be teaching you all the important things, right? So let's begin with the quote, and the quote for the day is going to be what behind every high achiever is a story of hard work and countless study sessions, right? I believe you have done your hard work in the last 5 months. You have done everything that you could have done, right? And the exam is really approaching soon, right? So you have to be in the same manner. Just try to be consistent, and everything will fall into its place automatically, right? Need not to worry. You will all pass. My best wishes are always with you, right? So let's begin with the first thing that we are having is about the cardiovascular system, right? So first chapter we are going to discuss about the chapter, what are the important topics in that chapter, and then we are going to solve what then we are going to look at the one-liner questions that has been asked previously through this particular thing, right? So let's begin with the first important topic that we are having is about the action potential. There is going to be this particular question in every examination you would be finding, be it FMG, be it NEET PG, or be it INI set examination. So let's just try to understand very simply what does this mean and how this is going to happen and what kind of question examiner is willing to ask us, right? So this is going to be the funda we are having. The first thing you need to remember, this is the story of a single contraction of a cardiac myocyte, right? So I'm just taking a cell for you. Just remember, this is one cell, this is another cell, these are your cardiac myocyte, these are different cells, right? One thing you have to remember, every cell will be having a window beta. Through this particular window, who is going to leak out? This is going to be potassium, and this is going to be your first question. The resting membrane potential is due to what? Resting membrane potential is due to the efflux of potassium. Always remember, this potassium is a very important ion for the resting membrane potential. Second question, sir, what is resting membrane potential? It is going to be the difference of current in the outside versus inside of the cell, right? So outside will be something, inside will be something. This is going to make a difference, and this is going to be what? Resting membrane potential. Potential means there will be difference of the current, right? So how this thing is going to happen, let's try to understand. I'm just taking a ventricular myocyte in front of you. This is a muscle cell of ventricles, right, of the heart, right? So what is going to happen, let's try to understand. RMP is for this particular cell is going to be what? Ventricular myocyte. Just remember, minus 90 millivolt is going to be there. This is the resting membrane potential. Now what is going to happen, look at me and follow the sequence. The first thing which is going to enter into the cell is going to be what? This is going to be sodium. So sodium is a positive charge beta. What is going to happen to this particular thing? It is going to get positive, yes or no? This is going to get positive, and if it is going to get positive till plus 20, it is going to get positive, and this thing is known as what? This thing is known as depolarization beta. The same thing you have to remember, positive means depolarization. We can also call it sometimes systole, we can also call it what? Contraction. So depolarization, systole, contraction, they are all the same kind of thing that you have to understand. This is going to make things easy for you, right? So any cell is getting positively charged, that means it is getting depolarized, it is getting systole, it is getting contracted, right? So first thing that is going to happen, because of sodium, what is going to happen? Sodium influx. Influx means sodium is coming inside. What is going to happen? The resting membrane potential is going to reach to plus 20. As soon as it will hit the plus 20, now you tell me what is going to open? Who is going to open now? Potassium channel beta. Very good, this is going to be potassium channel, and now potassium will be a positive charge. It is leaking out. What will happen to the current? It will come below, it will come below, it will come towards the zero, right? As soon as it will hit the zero, what will happen? Another thing will open. This is going to be what? This is going to be your calcium channel beta. And now calcium is a positive charge which is coming inside. Potassium is again a positive charge going outside. This is going to make a plateau phase, and this is going to make this particular plateau phase. This is your plateau phase is going to be what? Phase 2. This is going to be this is your phase number 2. And now what is going to happen? Now the last thing who is going to open? Now the last thing who is going to open is going to be your, again, your this potassium channel, and this potassium channel is going to throw out the potassium. Till what time it is going to throw out the potassium? Till the time, sir, it will come back to its original position, it will come back to resting position, it will come back to 0 again, it will come back to minus 90 again. This is what is known as what? It is going to come back to its original position. So some terms we have to understand here. This is the basic cycle that we are having. This is a single contraction that we are having. Now, if you understand one contraction, you will understand all the contractions in the body. Just try to understand this thing. Whenever a positive charge is coming inside a cell, can I call it a depolarized cell? Can I call it a systole cell? Can I call it a contracted cell? Yes, sir, I can call it, right? The same positive charge will travel to another cell now. Now another cell will get depolarized, now another cell will get depolarized, now another cell will get depolarized, and like this what will happen? The wave of depolarization or the information will travel in your body like this, right? So this is going to be how information is also traveling, how current is also traveling in our body, with the help of which ion? With the help of sodium ion, and this is going to transport the things in our body like that, right? I think about contraction here, how I can contract, I'll think about it, and this depolarization will be traveling like that. What happens to the backward cells, or it will come back to its original position? Yes or no? This will get depolarized, it will come back to its original position. Now repolarization is due to what? Because of the potassium efflux, and this potassium will leak out till what time? Till the time this cell will come back to its original position, that is minus 90 millivolt. That is what is known as resting membrane potential. I hope all these points are clear to you, right? So what is repolarization? Repolarization means coming back to its original negative position. This is also known as diastole, this is also known as relaxation, this is also known as coming back to its original negative position, right? This is the basic thing you have to remember. Now examiner is going to ask you what phase 4 is due to. He is going to write you phase 4 is due to, this is known as what? Resting potential or resting membrane potential. Phase 0 is due to sodium influx, and this is known as what? This is known as depolarization or action potential. Phase 1 is going to be what? This is going to be happening what? This is due to potassium efflux. In phase 2, what is going to happen? This is your exam question, previous year exam question. Phase 2 is due to calcium influx and potassium efflux. And phase 3, what is happening, beta? Who is going out in phase 3? Last thing, who is going out? This is going to be the potassium, right? So phase 3 is going to be due to potassium. Now we understand two concepts: how current, how anything is moving in our body. Second concept, how you are going to solve this question. This is going to be the normal cell that we are having. If this concept is clear, now I can teach you about the nodal cell. It is also very simple. Look here, suppose this is a normal cell that we are having. This is a normal nodal cell, right? But here one thing you need to remember: pacemakers are known as pacemaker because they do not have resting membrane potential. Rather, they will be having what? Restless membrane potential. Restless membrane potential. Restless membrane potential means what? The membrane potential is not like this fixed minus 90 or minus 70. It is going to be oscillating between a value of minus 60 to minus 40 millivolts. This is what is known as what? This is what is known as restless membrane potential, right? And here the phase 4 is also known as what? This phase 4 is known as pre-potential, beta. This phase 4 is important. This phase 4 is known as pre-potential. I'll teach you only those points examiner is going to ask you, right? So this phase 4 is known as pre-potential. Now this pre-potential is due to what causes? There should be what causes? If I want to make this cell positive, if I want to make this cell contract, if I want to make this cell depolarized, what I need to do? I need to put positive charge from outside. Yes or no? Yes, I am going to put positive charge. So what are the positive charge? First is funny sodium influx. Sodium is what kind of charge, beta? This is your funny sodium influx. This is going to cause the cell positivity. Second thing is going to be what? This is going to be T type of calcium channel. Very important, transient type of calcium channel. So who is going to come inside? Calcium. And we already know calcium is what kind of a charge? This is also a positive charge. And the third thing responsible for this particular thing is going to be what? Decrease in potassium efflux. We already know this potassium is what kind of a charge? Potassium is a positive charge and it is leaking out of the cell. If I block this thing, what will happen? This potassium will accumulate inside, and if this potassium will accumulate inside, this sodium will come inside, this calcium will come inside. What will happen to the potential? It will reach to this particular point very easily. Its threshold will be reached very easily. If positive charge will get accumulated, it will reach to the threshold very easily, and once it will hit this threshold, what will happen? Now you will be having activation of what? Depolarization. And this phase 0, this phase 0 is also known as depolarization. Here also, right? This phase 0 is due to what? This phase 0 is due to L type of calcium channel. These are going to be what? Long lasting calcium channel. L type, you can remember, L type calcium channel. So there is going to be two type of calcium channels are going to get involved. One is going to be this particular one. This one is going to be T type of calcium channel. T means transient, for some time, and this one is long lasting, which is going to cause what? Contraction here. And this is going to be what? This is known as action potential. Now the third thing is going to be what? Now again this cell is positive. Now it needs to come back to its original position. So what this cell will do, beta? This cell is going to remove out what? It will do the efflux of potassium. It is going to remove out the potassium, and what will happen? This cell will again come back to its original negative position, right? This is what is known as what? This is the pacemaker potential that we are having. If you understand one cell, you will understand multiple things, right? You can use multiple drugs, you can apply all the concepts that you know, like sympathetic, parasympathetic nervous system, everything will be, you can understand. This is what is 1 second, or one single contraction that is happening in a single second, right? This is SA node. So what is going to be heart rate? If there is one contraction in 1 second, heart rate is going to be what? 60. If I increase the slope of this pre-potential beta, just try to understand this concept. If I increase the slope of this pre-potential, can you appreciate we can get 2 contraction in 1 second? So if we can get 2 contraction in 1 second, what will happen to the heart rate? Heart rate will be doubled. You understand how the sympathetic nervous system will increase the heart rate? It will increase the slope of pre-potential beta. Parasympathetic will decrease the heart rate. We already know. Let's try to understand. It is going to decrease the slope of pre-potential. And if the slope of pre-potential is going to get decreased, what will happen? Sir, heart rate will also be decreased, because there will be only, let's say, half contraction in 1 second. So heart rate will be around 30, right? Just for the hypothetical thing, right? So this is a single contraction that is happening. Now how many things are responsible for this? This is going to be funny channel, right? You can block this particular thing with the drugs like ivabradine, right? Ivabradine is a funny channel blocker. If you block this, what will happen? It will not get contracted. It will not get contracted. What will happen? You will have decrease in the heart rate. That is what is going to cause what? Bradycardia. You can apply so that you can remember also, right? So this is the basic thing they are asking. Now what questions they are asking from here? The questions they are going to ask you from here is going to be pretty simple. Phase 0 in cardiac myocyte, ventricular myocyte is going to be what? This is going to be depolarization. This is due to what? This is due to sodium influx. First question. Phase 0 in SA node is going to be again depolarization. It is due to calcium channel, long lasting type of calcium channel. It is due to L type of calcium channel. Okay. Next thing he is going to ask you, phase 3 here is going to be due to what? Phase 3 is due to potassium efflux. Phase 3 is due to potassium efflux. Here also phase 3 is due to the same things, sir, potassium efflux. Then what question he is going to ask you? Phase 4. Phase 4 here it is going to be resting membrane potential, whereas here it is known as what? Pre-potential beta. Another question he can frame, pre-potential is due to all of the following except. So 3 things you have to remember. First, funny sodium channel. Second, T type of calcium channel. Third is going to be decrease in potassium efflux. These are the 3 causes. One cause he is going to write you, that is going to be the odd one out you have to make, and this is how you are going to solve this question. Is that okay with you? No issues, right? Resting membrane potential is going to be what? Minus 60 to minus 40 millivolt for SA node. For neuron, you have to remember that is going to be minus 70 millivolt, right? Neuron question he has already asked. If he asks you question, neuron or nerve potential is equal to, he is going to ask you one question, nerve potential is equal to, then you have to mark what? If he is going to ask you nerve potential is equal to, another question, nerve potential is close to, these are the two questions he is going to ask you. Whenever he is going to ask you the question is equal to, you have to mark the answer, that is going to be what? Chloride. That is going to be chloride, right? If he is going to write you close to, you have to mark the answer, that is always going to be what? Potassium. At least 2 times they have asked this question, right? Just remember this fact, you will be able to understand this, right? Or let me just give you the understanding. These are your resting membrane potential. For ventricular myocyte, Purkinje fibers, skeletal muscle, it is going to be minus 90 millivolt. For neuron, the resting membrane potential is minus 70 millivolt, right? What is equilibrium potential? This is going to be a potential at which there will be no movement of the ion. We calculate this thing with the Nernst equation, right? For example, here the equilibrium potential for potassium is going to be what? Minus 90. As soon as this cell will reach minus 90, what will happen? There will be no movement of potassium. This is what is known as equilibrium potential, right? So equilibrium potential for this potassium is minus 90 millivolt. For chloride, it is going to be minus 70 millivolt. For chloride, it is going to be minus 70 millivolt, right? So that is what you need to remember. If they ask you equal to, you have to write the answer, that is going to be minus 70. That is going to be what? Equal to chloride. If they are asking close to, that is going to be what? Potassium. Close to, if they ask you, answer should be potassium. If they ask you resting membrane potential is due to, then your answer should be potassium. All these questions has been asked previously, but these questions we are not going to make wrong. Another important topic is going to be this pressure volume loop. Here we have discussed, right? This is going to be your right atrium, right ventricle, left atrium, left ventricle, and the blood will be coming, deoxygenated blood coming to the right atrium, going to the right ventricle, then again coming back to the left atrium, oxygenated from the lungs, right? And this oxygenated will be going to the left ventricle, and then it will be going to the aorta. Then it would be going to the aorta, right? So you need to understand about certain valves. What are the valves we are having? Here we are going to have some valve. This valve is known as what? This valve is known as aortic valve. Here you will be having aorta. Here you will be having lungs, so that would be your pulmonary valve will be here, right? Here deoxygenated blood would be coming. Now I'll just try to make you understand this simple diagram. Once you understand this diagram, you will be understanding all basic functioning of the heart, right? So what is going to be the basic functioning of the heart? Let's just try to assume this point as a B point. This is your C point, this is your D point, and this is going to be your A point, right? So what is going to be there? Just assume at point B, I'm telling you, there is 120 ml of blood is going to be there. So at point B, how much blood is there? This is going to be 120 ml. And this point B, just imagine in the left ventricle, you are having what? 120 ml of blood. Try to imagine in the same fashion, like I will be teaching you about this side of the heart, you will understand this will work simultaneously, right? So here how much blood is there? This is 120 ml. Now can I open this valve directly? No, I need to generate the pressure, because I need to send this blood directly to the complete body. And remember, this wall of ventricles are going to be thick. They are very thick. They are going to generate the pressure, right? So how they are going to generate the pressure? This is a pressure volume loop, so you have to understand this is going to be generating the pressure. This is how it is going to generate the pressure. And what is going to be this phase is known as isovolumic contraction. Iso means same, volumic means volume, so volume is same. What is the volume? 120 ml. And contraction means what is happening here? You are generating the pressure. Once you will generate the complete pressure, what will happen? This valve is going to get opened. So they are going to ask you another question. At point C, what is going to happen? You have to mark your answer. At point C, who is going to open, beta? Aortic valve is going to open, right? After opening of aortic valve, what will happen? Out of this 120 ml which was there, what will happen? Some amount of blood will be going to the body. From aorta, the blood will be going to the body. Here you will be having phases. These are your rapid ejection, your slow ejection phases are going to be there, right? And after that, at point D, what should be happening, beta? Now the blood is going to the complete body. Now we need to close this particular valve, and at point D we are going to close which valve, beta? We are going to close the aortic valve. So point D, we are going to close the aortic valve. Point D is due to aortic valve closure. And we already know if there is going to be a closure of any valve, you are going to get a sound, right? So at point D, you are going to get a sound, and this sound is due to the closure of aortic valve. Now the aortic valve is closed, and how much blood is going to go out? But at 70 ml it is going to throw away, right? And what is the amount of blood which is going to stay here? This is going to be 50 ml. So out of 120, 70 is going out, 50 is going to stay here, and now this valve will be closed. Now this valve will be closed, but do you know the pressure here is going to be what? This is going to be high, right? It is already high. If I open this valve, what will happen? You can have regurgitation, right? So I'm not going to open this valve. First I need to do what? I need to decrease the pressure beta. First I need to decrease the pressure, and this particular phase is known as what? Isovolumic relaxation. That means what is the volume here? 50 ml. At 50 ml I am going to decrease the pressure, right? Till what point I am going to decrease the pressure? Till the point A. At point A, what will happen? The pressure will be 0. This is going to be the pressure, right? So at point A, the pressure will be 0. When the pressure will be 0, now who can open beta? Now I can open the mitral or bicuspid valve. This is mitral or bicuspid valve. Now I can open this, and now what can happen? Now you can have the increase in the volume. Volume will be here. So now you can have what? Now you can have filling from the above part of the heart, that is going to be from the atria. So now you can have what? Filling from the atria. And at point B, when you have what? Filling completed, 120 ml will be completed. So at point B, what should be getting closed beta? Here you should be having what? At point B, what should be getting closed? There should be closure of which valve? Closure of, at point B, there should be closure of mitral valve, closure of mitral valve, and closure of mitral valve is going to give you some sound, and this is going to be with sound, S1 sound. Here you will be getting another sound, that is known as what? S2 sound, right? So this is going to be the cycle which is happening. We have read this cycle in the great detail, right? I've just given you the brief outline, right? And whatever part we have divided this cycle into two halves beta. Whatever part is going to be in this cycle, contraction, I told you, contraction, ejection, this is going to be what? This is going to be systole. This is known as systole. And whatever is going to be opposite to that is going to be what? Isovolumic relaxation. Slow filling will be here, rapid filling will be here. This is going to be what? This is going to be relaxation phase. So this is known as what? Diastole. This phase, this cycle is divided into two halves. The above part is going to be systole. Whenever there is contraction, ejection, everything is going to be what? Systole. Whereas this particular part is going to become what? Diastole, right? So what is going to be the another thing that you need to remember? What is end diastolic volume? This is going to be what? This is going to be 120 ml, because this is diastole. At the end of diastole, what is the volume? At the end of relaxation, what is the volume? This is known as end diastolic volume, 120 ml. At the end of systole, what is the volume? This is going to be what? 50 ml. So 50 ml is going to be what? End systolic volume, and here 120 ml is going to be what? End diastolic volume. These are the basic concept you need to remember. Now let me tell you how many questions they have asked and how they are asking the question. They are going to mark a point and they are going to ask you what is going to happen at point C. So you need to remember, at point B you will be having 120 ml blood. First you will be having isovolumic contraction. In fact, they have asked this question, what is this phase is known as? This is known as isovolumic contraction. Here you will be having blood, and this is going to increase the pressure. At point C, who is going to open? This is going to be aortic valve, and then you will be having rapid and slow ejection. How much blood is going out? That is going to be 70 ml. How much is left? That is going to be 50 ml. Whatever is left is known as what? End systolic volume. Now can I open this? No sir, I cannot open this. I need to decrease the pressure, and decrease in the pressure is known as what? Isovolumic relaxation. How much blood is there? 50 ml. How much blood is there? 50 ml is going to be there. 70 is going away. 120 out of 120, 50 is there. Now you will be again having at point A, if they ask you who is going to open, at point A mitral valve will open, and now you will be having filling till 120. And at point B, who is going to get closed? This is going to be closure of mitral valve. Very simple. Just make it for once and you will remember this cycle forever, right? This is going to be the basic cycle. So at point D is due to closure of aortic valve. Point B is due to closure of mitral valve. B point is going to give you S1 sound, whereas D point is going to give you as 2 sound. This is the basic cycle that you need to remember. They give you image and they are going to ask you what is going to happen at what part. Okay, so I hope this is sorted for you, and this is going to be what pressure volume loop. Now next thing we are having is about the jugular venous pressure beta, JVP, right? You can simply remember the JVP is also going to be correlated with the same thing. There are going to be 3 waves. A wave is going to be there, C wave is going to be there, and V wave is going to be there, and there are going to be 2 descents. These are your X descent and Y descent, right? So just try to understand what is this A wave is indicating. A wave is indicating about the atrial contraction. Sir, ये JVP क्या बताता है? What this JVP is going to tell you about? It is going to tell you about the situation of only and only right atrium beta. Right atrial situation is going to be understood with the help of what? JVP. JVP is talking about what? Right atrium, right? So what is going to happen? A wave is going to tell us about the atrial contraction, right? The pressure will be increased when there will be more fluid is going to be here. This pressure is going to get increased. This is going to be A wave. After this particular thing, this blood will be accumulated where beta? This blood will be accumulated in the ventricles, we already know. And when the blood will be in the ventricles, is it going to open directly? No. First I need to cause what? Isovolumic contraction. So this C wave is where? C wave is going to be what? The C wave is due to isovolumic contraction. So C wave is going to be what? When this ventricles are contracting, what will happen? This tricuspid valve is going to bulge into right atrium beta. This ventricles are contracting so that it can generate the pressure, right? Isovolumic contraction is happening. At this point, what will happen? This particular right ventricle is trying, or tricuspid valve is bulging into the right atrium. This is going to give you what? This is going to give you C wave. C wave is due to ventricular contraction. Tricuspid bulging has been asked previously. Exact the C wave is due to what? Right? Your answer will be this is due to bulging of tricuspid valve into right atrium. During which phase? During isovolumic contraction, right? Here you will be having 120 ml of blood. Same thing is happening. Now what will happen? Who is going to open? Pulmonary valve, here aortic valve, right? So 120, same thing will be happening, right? So what will happen? Now this blood will be going to the body, and this X means relax. You can remember. Now what is going to happen? Atrias are going to relax because the pressure is going away. This is going to be X wave. Now you will be having V for venous filling beta. V for what is happening? V for venous filling is happening. Now again what will happen? Now blood will start to fill into the atrias, right? And because of filling of blood into atria, again there will be increase in the pressure of the atrias, right? And this particular thing, after the blood will be there in the atria, who is going to open beta? Who is going to open? Mitral and tricuspid valve. Due to that, what will happen? This blood will be coming here, and this is going to be what? This is going to give you Y wave. And this Y is telling us about what? Y means, you can simply remember, Y means empty. If you understand, well. If you don't understand, just remember the things that you have to remember. Look here. A wave is about the contraction. A for atrial contraction. C for, this is, you have to remember, ventricular contraction, tricuspid bulging. X for relax, atrias relax. V for venous filling, and Y for emptying. Y for emptying. This is what you can remember, and you can solve your questions, right? Now some reflexes are going to be there. We have got certain reflexes. They have been asked very frequently in the examinations. What are the reflexes you have to remember? The first one is known as what? Bain bridge reflex. First one is your Bain bridge reflex, right? It is triggered by the increased venous return. Whenever there is going to be more blood coming into the right atrium, what will happen? In response to this particular thing, whenever there is increase in venous return, what will happen? Here you will be having SA node, right? So it is going to activate what? It is going to increase the SA node. It is going to increase the SA nodal action, and because of that, what is going to happen? Due to increase in venous return, you will be having what? You will be having increase in the heart rate. This is what is known as what? This is known as Bain bridge reflex. Very simple. Second thing is going to be what? Bejold-Jarris reflex. This is going to be due to ventricular stretch. This Bain bridge is due to atrial stretch. This is due to excessive ventricular stretch, or maybe due to any kind of chemical stimulation. It will result in what? Bradycardia, hypotension, and vasodilatation. This is a protective reflex we are having, known as what? Bejold-Jarris reflex. Cushing means pushing. Where is the pushing happening? Cushing is for the pushing, you can remember like that, right? So this Cushing reflex is triggered by intracranial pressure is going to get increased. Whenever there is increase in intracranial pressure, what will happen? It will cause what? Hypertension, bradycardia, and irregular respiration to maintain the cerebral perfusion, right? It will increase the BP so that blood can go to the brain. That is what is more important. It will do what? Bradycardia also, and irregular respiration can also be seen. This reflex is known as Cushing reflex. All these three has been asked previously, right? One test is also there, that is known as Zermar-Herring test. That is what we are doing when we are doing the carotid massage. It will decrease the BP of the person, right? Now, what about this heart sounds? We have got three types of we have got this particular thing. This is known as cardiophonograph, right? So what is going to be the mnemonic? You can remember simple mnemonic. You can remember that you can answer all these three questions, right? So they are going to ask you ECG correlation on the basis of heart sound, right? So you can remember R wave is due to what? R wave is due to, sorry, you can remember when you are going to have S1, when you are going to have S2, and when you are going to have S4 sound, right? This is how you can remember. So at the peak of R wave, you can appreciate at the peak of R wave, you are going to get what? You are going to get the S1. At the end of T wave, at the end of T wave, you are going to get the S2 sound. This is going to be PQRS T, right? So at the end of T wave, you are going to get which sound? At the peak of R, you are going to get S1. At the end of T, you are going to get S2. And when you are going to get S4 sound, this is going to be at the end of, this is going to be which sound? This is going to be S4. This is going to be S4. So this S4 is going to be when? At the end of P wave. At the end of P wave, you are going to get S4 sound. So this is how you can remember RTP, R4 at the peak of R wave, at the end of T wave, at the end of P wave. This is how you can remember S1, S2 and S4 sound, right? So these are the important topics from this particular chapter. You have to remember from the CVS, right? Now some one-liner questions. Let's try to answer these questions, right? These are some basic questions they have asked to you, right? The first question we are having, impulse is generated from, you all know the impulse generation is going to take place in the SA node. This is going to be the SA node beta. Very good. Gatekeeper of heart is also known as, these are like 2018-19 question. Gatekeeper of heart is going to be what? This is going to be your AV node, right? In JVP, C wave is going to indicate what? Just now we have seen C wave. In JVP, C wave is going to indicate what? This is going to be the tricuspid bulging, the bulging of tricuspid valve into the right atrium during which phase beta? During isovolumic contraction, right? So JVP, C wave is going to indicate what? Bulging of, this is going to indicate what? Bulging of tricuspid valve into the right atrium during which phase? During isovolumic contraction, right? In JVP, absent A wave is going to indicate what? Absent A wave is going to indicate what? This is going to indicate the atrial fibrillation. Absent A wave means what? A wave is telling us about the atrial systole, atrial contraction. In fibrillation, what happens? Atrias are not contracting completely, they are fibrillating beta, they are fibrillating. So in atrial fibrillation, which wave is going to be absent? This is going to be A wave, your previous year question, right? RMP of neurons, RMP of nervous system is equal to, now you have to answer, I have given you the concept. This is going to be equal to nervous system, RMP is going to be equal to resting membrane potential is going to be equal to what? And RMP of nerve is going to be close to, this is going to be close to what? These are the two things you have to tell me. RMP is equal to what? Nervous is going to be what? Equal to, the RMP of nervous system is going to be -70, neurons is going to be -70, and what is going to have the equilibrium potential of -70? That is going to be your chloride. So answer is going to be what? Chloride. If they ask you RMP of nerve is close to, that is going to be, always remember, potassium is going to be the answer, right? So two things you have to remember. If they ask you about close to, multiple times same question. If they ask you about equal to is going to be what? Chloride, and close to is going to be what? Potassium. Close to is going to be what? Potassium. Now we'll discuss some questions about the general physiology basic that you have to remember. This tight junction is going to be due to what beta? This tight junction is due to what? Some proteins like clotting and occludin. What proteins are going to be there? Clotting and occludin proteins are going to be there, and they are abundant in which part? your blood brain barrier, your blood testis barrier, they will be having what? Tight junctions, right? Adherent junction is going to be associated with the E-cadherins, your actins, E-cadherins, right? Desmosomes are going to connect what? They are going to connect two keratinocytes, right? So desmosomes are responsible for the connection between two keratinocytes. Two keratinocytes are binded together with the help of what? Desmosomes. And if there is mutation in this desmosome, or if there is any kind of IgG antibodies or C3 deposit against this desmosome, this is going to cause a disease known as what? Pemphigus. This disease is known as what? Pemphigus, intraepidermal disorder, right? Gap junction are made up of what, beta? They are made up of connection protein, and if there is mutation of this connection, this is going to cause which disease? That is known as Charcot-Marie-Tooth disease, right? And these hemidesmosomal proteins, they are going to connect two desmosomes are two keratinocytes are connected with the help of desmosomes. Now they are connected to the basement membrane with the help of these things are known as what? Hemidesmosomes, right? So if you have mutation against this hemidesmosome, some proteins are there like BPAG1, BPAG2, right? We have got integrin, plectin, right? So if there is mutation of this hemidesmosomal proteins or antibody production against this hemidesmosomal protein, this is going to cause a disease known as bullous pemphigoid, beta. Bullous pemphigoid, right? So these things you have to remember. Tight junctions made up of claudin and occludin, right? Next thing is about the signaling. They have given you this particular image and they have asked you what kind of signaling is this, right? So always remember, when this particular thing is going to help himself, right? This is going to be known as what? Self-service. This is something which is helping to himself. This is going to be what? Self-service. If some local mediators are coming and working on the same cell, this is known as what? Autocrine, right? What are the examples of these things which are coming out from here are known as what? Autocoids. They are known as autocoids. In autocoids chapter in pharmacology, you have studied about this thing like your histamine, serotonin. What are these things? They are going to prostaglandins. They are going to be what? Autocoids, right? Second thing, signaling across the gap junction. Just now we have seen in the cardiac myocyte, they are going to have what? These are gap junctions, and gap junctions are made up of what? Connection. Third thing is paracrine. Paracrine is also, you can call it sometimes juxtacrine. Para or juxta means what? Nearby, right? So this is going to be what is happening. Can you appreciate? The things are coming from here and they are going to the nearby cell. So this is going to be the target cell, which is going to be the nearby cell. This type of signaling is known as what? Paracrine or juxtacrine signaling. Endocrine type of signaling means what? They are going to release their hormones directly into the blood. For example, thyroid is going to release everything directly into the blood. It will travel all around the body. It will bind some globulins, it will bind to some receptors, so it is going to be in the blood itself. So endocrine substances which are coming, they are known as what? Hormones. And remember, beta, hormones are always going to where? They are always going into the blood. So this is how you can answer this type of question. If you see this type of picture, you can answer this is paracrine, right? If you see some blood vessel is there, this is going to be what? Endocrine. And instead of blood vessel, if they write you duct, this is going to be what? Duct. What are the glands with the ducts? These are going to be what? Exocrine glands are known as the glands with the duct, right? Endocrine are going to be what? Ductless gland, right? So this is going to be about the important thing. Now about the next thing they are going to ask you is about the transporter, glucose transporters, right? So these are the glut. They are going to ask you, glut is example of what? Facilitated diffusion. Is it going to require energy? Is it going to use ATP? Is it a active transport or a passive transport, beta? Remember, this is going to be a passive kind of transport, and this is going to be having what? This is known as what? Facilitated diffusion. So always remember, glut is an example of facilitated diffusion. Another example for facilitated diffusion you have to remember has been asked previously. These are going to be what? Aquaporins. So two example you have to remember, glut and aquaporins are the examples of facilitated diffusion, right? This glut one is going to be present in the RBCs, your blood brain barrier. Glut 2 is going to be where? 2 for 2, you can remember, this is going to be present in the kidney, in the liver. This is going to be present. This is going to be what? Glut 2, right? It is going to be a bidirectional thing. It is present in your gastric mucosa also, right? Your intestinal mucosa also. Whereas this glut 4 is going to be present where? Glut 4 is present in the skeletal muscle, in the cardiac muscles, in the adipocytes. So cardiac muscle, skeletal muscle, adipocyte will be having which glut? This is insulin dependent glut. This is going to be the glut 4. Always remember glut 4 is going to be there, right? Beta cell of pancreas is going to be what? Beta cell is going to be what? 1, 2. That is going to be glut 2. Glut 5, F for 5, F for fructose beta. Glut 5 is for what? Glut 5 is for the absorption of fructose. These are going to be the things you have to remember. Now apart from gluts, we are having what? SGLT, very important, SGLT. Okay, SGLT is going to be a secondary active transport. That means they are going to be what? Active transport, passive transport. They are going to be active kind of transport. That means they are going to use ATP. Yes sir, they are going to use ATP, right? What are the two examples you have to remember? SGLT1, SGLT2. Okay, sodium glucose transporter 1 and 2. So this is going to be what? This is going to absorb sodium and glucose together. Sodium and glucose together, they are present majorly on the small intestine, and they are the basis of giving what? ORS. We remember in the ORS we are giving same concentration of sodium and glucose so that both the things can go directly inside, right? That is the reason we are giving what? ORS. And ORS will take up whatever amount of sodium will go inside. One concept we already know. Who is going to follow sodium? Sodium is like a beautiful girl. Who is going to follow? This is going to be your water. Water is like the boys, right? So water will always follow sodium, right? Simple understanding. So what we need to do, we need to put salt, automatically water will go, and this pump is going to be what? Sodium glucose pump. That is the reason we are having same amount of sodium and same amount of glucose, same osmolarity we are going to use for this particular thing for the ORS, right? This is the basis in the ORS. This is your exam question. They have asked why we are giving ORS. What is the basis behind this? So basis is going to be what? SGLT pump. We already know. Even your grandmother already know this thing, right? She is putting what? Salt and sugar together, right? If you are having diarrhea earlier, she used to give this particular thing. This is a homemade ORS, right? Same funda. SGLT2 is going to be present where? It is going to be present in the proximal part of the kidney, and it is going to be absolutely reabsorbing what? 100% of the glucose. It is going to get reabsorbed, but through a certain value, because it is going to be a pump, right? And those pump which are like working with the energy, right? They will be having a threshold value, right? So remember, this is going to be present in the kidney, and this is going to be present where exactly in the kidney? In the proximal convoluted tubule. And what it is going to do, it is going to absorb glucose over there, and that is the reason normal individual is not going to have what? Glycose-urea, because this PCT will be having pump which is going to absorb what? 100% of the glucose. But if you eat too much of glucose, or maybe you have hyperglycemia, maybe you have diabetes, in that particular case this pump might not work, and that is what we need to remember. We can also block this pump with the help of some drugs, and these drugs are going to be what? Gliflozins. Gliflozin. You can remember this gliflozin, glucose flows in urine, right? So if I give SGLT2 inhibitor, if I block this pump, what will happen? This 100% glucose which is getting reabsorbed will go out into the urine, and if it will go out into the urine, you can understand this thing will lead to what? Glycose-urea. Okay, so these are the glut. At least you have to remember this glut 2 will be present in beta cells of pancreas. Glut 4 will be in the skeletal muscles, right? SGLT1, SGLT2 in the small intestine and proximal kidney, right? If they ask you about the ionic composition beta, you have to remember what is the most abundant dominant cation is going to be what? Here in this particular side we are putting what? Cations. Here this is the extracellular compartment outside the cell, this is intracellular compartment inside the cell, right? Anion means negative charge. So what is going to be most abundant extracellular cation? Extracellular cation is going to be what? This is going to be sodium. Sodium value somewhat around 140, right? This is going to be sodium. If they ask you most abundant intracellular anion, this is going to be this particular one. If they ask you most abundant extracellular anion, this is going to be the chloride. If they ask you most abundant intracellular cation, then you need to think about what? Potassium, right? Inside the cell, outside the cell, right? So what is going to be inside the cell? What is going to be outside the cell? Main ions you have to remember. They have asked a question, most abundant extracellular cation. I hope you can remember and you can answer. Most abundant extracellular cation means what? Sodium is going to be your answer, right? So this is how you can remember this question. Another question they have asked you is about the clotting cascade. What is this clotting cascade we are having? This clotting cascade or coagulation cascade that we are having, it is responsible for what? It is responsible for primary hemostasis or secondary hemostasis, beta? It is responsible for secondary hemostasis. It is responsible for what? It is responsible for secondary hemostasis. Primary is due to weak platelet, right? So we have got two pathways. We have got extrinsic pathway, we have got intrinsic pathway. We have remembered this thing with the help of mnemonic, right? So extrinsic will be factor number 7. Common pathway will be having 1, factor 2, factor 5, and 2 5s are 10. That is going to be factor number 10. Remaining is going to be what? 8, 9, 11, 12. These are going to come inside the intrinsic pathway. This is what we have already seen, intrinsic and extrinsic pathway. This is what we have already seen, right? Now what is the purpose of this particular cascade? The purpose is to make what? Fibrin out of fibrinogen, right? The ultimate purpose of this cascade is to make what? Fibrin. And this fibrin is going to responsible for what? Secondary hemostasis. The secondary hemostasis that we are having, this is due to what? This is due to this fibrin plaque. This fibrin plaque, and this fibrin is going to be made up of what? This is going to be coming out of what? This is going to be coming out of fibrinogen. This is fibrinogen, which is a plasma protein, is going to convert into fibrin, right? The examiner has asked question, this conversion of prothrombin to thrombin require which ion? The answer will be what? Calcium. Very important. This calcium is responsible for what purpose? The conversion of prothrombin, that is factor number 2 to factor number 2a, is going to be catalyzed with the help of reaction, is going to get catalyzed with the help of calcium. So they have asked this question, and this is going to be your answer. We can remember this, right? This is the thing you have to remember. Okay, next question they have asked is about the transport. We have seen two types of transport are going to be there. We can have passive transport, that means without the energy. We can have active transport with the energy, right? Without the energy, we can have facilitated diffusion, that is going to be having two example. One is aquaporin, another one is going to be your glut receptors that we have seen. In active transport, we are having two things. One is endocytosis, one is exocytosis inside this vesicles, right? Endocytosis means to engulf something, exo means to take this, give something out, right? Remember, this endocytosis is due to two important protein. These are going to be your megalin and clethin. Megalin and clethin, your Neet PG PYQ, right? And this exocytosis is due to which protein? These are going to be your snare protein, beta. Very important, snare proteins, right? If the substance you are engulfing is solid, we call it what? Phagocytosis. Sometimes they can write you, if the material is liquid, we call it what? Pinocytosis. You drink water, right? Like that, pinocytosis. In the pump, we have seen primary and secondary active transport will be there, right? This is going to be the pump, right? For secondary active transport, remember, primary is going to be what? Whatever sodium ATPase pumps are going to be there. Proton pump is going to be what? Primary active transport. Secondary active, we have seen all your transporters with the symport, right? Your antiport, symport, antiport, co-transporter, these are going to be what? These are your secondary active transport, right? So we have got primary active, we have got secondary active transport. This is about the transport. You have to remember 3-4 points you have to remember about endocytosis. These are your megalin and clethin. For exocytosis, that is going to be the snare proteins, right? These are the facilitated diffusion. We have got aquaporin and glut as a answer, right? Now try to solve some one-liners. What is the most abundant extracellular cation? Most abundant extracellular cation, your answer will be what, beta? सबसे ज़्यादा क्या होगा सेल के बाहर? सबसे ज़्यादा क्या होगा? सोडियम होगा, पोटेशियम होगा, क्लोराइड होगा. What would be your answer? Yes, this is going to be extracellular cation. We already know outside the cell who is going to be more. Sodium is going to be more. Inside the cell who is going to be more? Potassium is going to be more, right? Which glut is present in adipocytes for uptake of glucose? Insulin dependent adipocytes. This is going to be your, very good, this is going to be your glut number 4, glut 4. What is calcium binding protein in the smooth muscles, right? In the smooth muscle, the calcium binding protein is known as calmodulin, right? Normal anion gap is going to be what? Normal anion gap is going to be what? Just remember this value, 8 to 12 milliequivalent per liter. This is going to be normal anion gap, right? Rabies virus uses what for the movement? Rabies virus will travel in your body from the lower part to the upper part with the help of what? With the help of dynein, right? With the help of dynein. Dynein will be having cilias, and this dynein is responsible for which kind of transport? Reverse axonal transport, reverse axonal transport, right? Dynein is responsible for reverse axonal transport, and if you have mutation of this dynein, which syndrome will occur? That is going to be what? Carter-Jenner syndrome. Carter-Jenner syndrome, which will be having a triad. What is the triad? B for bronchiectasis, bronchiectasis. D for dextrocardia, BDS is the triad, dextrocardia. S for sinusitis is going to be there, right? And you can have what? You can have infertility also, infertility also, right? So this is going to be the triad for what? This is going to, BDS is going to be the triad for Carter-Jenner syndrome. Okay, next one is going to be what? ORS is the basis for transport of what? This is going to be, what is the basis? SGLT1 pump is going to be there in the intestine, right? Decrease free radical injury and increase lifespan is going to be by, how you can decrease the free radical injury? By decreasing the calorie intake. But in the question they have written what? They have written the other thing, that is going to be what? Sirtuins, right? And the sirtuins you will be finding in the red wine, right? This is going to be the thing. We can also have what? Antioxidant, antioxidants, right? We know these free radicals are known as reactive oxygen species. We can kill them with the decreased calorie intake, we can kill them with the antioxidant, we can also kill them with the sirtuins, which is something which is going to be present in the red wine, bitter red wine. Okay, the next system we are having is the respiratory system. In respiratory system, they are going to ask you, they are going to give you this diagram very classically, the same format they are asking multiple times. They will write you this diagram, and they will ask you what is this point A, what is this point B, right? So how you will identify? This is going to be what? Tidal volume. Normal tidal volume is going to be what? 500 ml. 4 volume you have to remember. One is going to be normal inspiration, expiration, known as tidal volume. Another one, maximum inspiration, only inspiration I'm talking about, is going to be what? Volume. Maximum inspiration is going to be what? This is going to be inspiratory reserve volume. Maximum expiration is going to be what? Expiratory reserve volume. And there is always going to be some volume which you cannot change. Like you inflate a balloon once, you will always have some air inside that you cannot change. The same thing will happen with our lungs. Once you inflate it, there will always be some air which you cannot change, right? This is going to be known as what? Residual volume. So 4 volume, what are those 4 volume? You can remember this particular thing with the help of a mnemonic, how to identify what kind of question they will be asking you, right? You can remember the mnemonic. Volumes, you can write down capacities, right? When you combine two things, they will become what? Capacity. 4 volume, you have to remember these are going to be Reti, TVI is the mnemonic, beta. Reti, TVI is the mnemonic, right? So what are the 4 volumes that you know? The 4 volumes that you know is going to be what? Residual volume, which is always going to be there. Expiratory reserve volume, that is the maximum expiration. Tidal volume means normal inspiration, expiration, and inspiratory reserve volume is maximum inspiration only, right? These are the 4 volumes. Capacities, we can have inspiratory capacity, vital capacity, we can have total lung capacity, right? So what is this? How you will calculate this particular thing? You can combine these two. RV plus ERV is going to become what? FRC. This is going to be functional residual capacity. Okay, ERV plus tidal volume, maximum expiration plus tidal volume, this is going to become what? Expiratory capacity. Rest is simple. Tidal volume plus maximum inspiration is going to become what? This is going to become what? Inspiratory capacity. Expiratory capacity, tidal volume, and inspiratory capacity. Maximum inspiration, maximum expiration, along with the tidal volume, all these three are going to comprise what? Vital capacity. And when you combine all the volumes together, this is going to become what? This is going to become total lung capacity, total lung capacity, right? So we have got FRC, we have got EC, we have got IC, we have got VC, we have got TLC. This is how you can remember this particular cycle. These are the questions they are going to ask you. So if you remember this particular thing, you can answer these questions very nicely, right? This complete area they can give you. So it will be having what? RV and this ERV. What it will become? RV and ERV. This is going to become what? This is going to become FRC, right? If they will write you another thing, they will be writing you maximum expiration plus tidal volume. This is going to become which capacity? This is going to become expiratory capacity. These two things are going to be there. If they give you tidal volume plus maximum inspiration, this is going to become what? Inspiratory capacity. If they write you maximum inspiration, maximum expiration along with the tidal volume, this is going to become what? Vital capacity. And if you combine everything, this is going to become what? Total lung capacity. The only thing you need to remember is functional residual capacity. Remember, other things are going to be simple, right? The next question they are going to ask you is about the hemoglobin oxygen dissociation curve, right? Hemoglobin oxygen dissociation curve. So what is this hemoglobin oxygen story? Hemoglobin is always combined with what? Oxygen. They are always together. They are the brothers for life, right? So they are always together, or maybe they are couple, right? So this hemoglobin is a couple with oxygen. Now they are asking about when you will have right shift, when you will have left shift. The only thing you need to remember, R means reduced affinity beta. Reduced affinity. No need to mug up this particular thing, just understand this thing and you will not get the question wrong, right? Reduced affinity means what will happen when you will have the breakup, when you will have this combination is going to get released, right? So what is going to happen? This oxygen is going to be coming out of this particular hemoglobin. The function of hemoglobin is to give oxygen, and this is what we are going to plant a curve over it. This is known as hemoglobin oxygen dissociation curve, right? So what is going to happen when this oxygen is going to get released from the hemoglobin? Whenever there is going to be hypoxia situation, yes or no? So whenever there is hypoxia, this hemoglobin will leave oxygen and it will tell the oxygen you can go now, right? This is going to be what? Whenever there is hypoxia. Hypoxia means what, beta? Decrease in oxygen. Decrease in oxygen, that means what should be getting increased? That should be your CO2. Can I say increase in CO2? Increase in CO2. Who is the brother of CO2? I already told you H plus and CO2 are brothers for life from now onwards till the end of your life. Remember, simple concept, right? H plus and CO2 are together. Increase in H plus, can I also call it acidosis, beta? Can I also call it acidosis, right? Increase in H plus is also known as acidosis. And what happens in acidosis? What happens to the pH? Sir, pH will be decreased, right? What happens with the temperature? You can remember when someone is going to put temperature over there, right? कोई आग लगाएगा तो क्या होगा? When someone is going to put fire, what will happen? They are going to have breakup, right? So increase in temperature will also lead to what? Breakup. This 2,3-DPG is a product that you will be finding in the blood, right? This is also going to increase what? This is also going to increase what? Breakup, right? So all these things are going to cause what? Right shift of the curve, and right shift is going to be due to hypoxia mainly. One concept you understand, you are not going to make the question wrong. This is going to be seen in the cases of any cases of hypoxia, right? So hypoxia is going to be there, and this particular right shift of the curve is known as which effect? This is known as Bohr effect, beta, Bohr effect, right? Whereas left shift is due to what? And left shift will be having what? Left is going to have what? Here you will be having increase in affinity, beta. Increase in affinity means this hemoglobin and oxygen, they are tightly bounded now. They are not going to lose, right? Why they are not going to lose? This is going to have what? Already, because there is increase of oxygen is going to be there, right? Increase in oxygen is already there, and because of that, what is going to happen? You will be having what? Decreased levels of CO2. Decreased level of CO2 means what is happening? Who is going to get decreased? This is going to decrease the H plus also. H plus decrease means what? Acidosis or alkalosis. This is going to be what? Alkalosis situation. And what happens to the pH? pH is definitely going to get increased because it is alkalosis, right? What about the temperature? Temperature is going to get decreased, right? So whenever you are going to have high affinity, just for the understanding, whenever you are going to have high affinity, this hemoglobin is not going to release the oxygen. This graph is going to shift to the left direction. That means whenever hemoglobin is not releasing oxygen, this is shifting to the left direction. Simple understanding, right? And this shift is known as what? This is known as Haldane effect. Which effect, beta? This is known as Haldane. L for L, you can remember. Left shift will be there. This is going to be Haldane effect, right? So these are your hemoglobin oxygen dissociation curves and lung volumes that you have to remember. Now about the hypoxia, they're asking question about hypoxia. We can have four important types of hypoxia you need to remember. One is hypoxic hypoxia. That means there is decrease in the partial pressure of oxygen. Oxygen is already come. Hypoxia is there, leading to what? Hypoxia in the patient. This is going to be decrease in PO2, decrease in oxygen saturation. This thing can happen in high altitude, pneumonia patients who is not able to breathe, right? This is going to be the hypoxic hypoxia. In anemic hypoxia, what is going to happen now? Due to anemia, what is going to happen? You will be having decrease in the hemoglobin, and if there is decrease in the hemoglobin, who is going to be low? Who is going to be low? Hemoglobin will be low. That means oxygen transport will be low. If oxygen transport will be low, what will happen? You will be having what? Again, anemia situation will be there, right? You can have this thing in the anemia. That is why the person is going to have less energy production, less oxygen is reaching to the mitochondria, less aerobic respiration, right? Less aerobic glycolysis, right? And if there will be less aerobic glycolysis, person will be having lethargy, person will be feeling weak, fatigue will be there, all the symptoms will be there. He might have air hunger also, right? He requires what? He will be doing what? Hyperventilation to gain the oxygen, right? In carbon monoxide poisoning, this thing can also happen. The same story is going to be there. Circulatory hypoxia or stagnant hypoxia is going to be what? Suppose this is a vessel. Now you will be having what? Some kind of atherosclerotic plaque is going to be there. This thing can lead to what? This thing can also lead to stagnant type of hypoxia, right? Because of this plaque, what will happen? You will be having ischemia, and because of ischemia, it will lead to what? It will lead to hypoxia, and that would be your circulatory, or that would be your stagnant type of hypoxia. Fourth type of hypoxia is going to be histotoxic. Histo means tissue, right? Here the oxygen is going to be normal partial pressure of oxygen, normal saturation, but tissue is not able to use the oxygen, and this thing is going to happen in the cyanide poisoning beta. In cyanide poisoning, it is going to happen, it is going to block the enzymes in the your etc cycle, right? This is going to be the problem that can happen, right? For cyanide poisoning, the drug of choice is going to be what? Your vitamin B12, right? Vitamin B12 analogs. This is going to be what? For the cyanide poisoning, right? So these are the four important types of hypoxia you have to remember. Hypoxic means decrease in oxygen, anemic means decrease in hemoglobin, circulatory means there is some kind of stagnation, and histotoxic means oxygen is there but tissue is not able to use this. This is going to be seen in the classically cyanide poisoning. Now some types of breathing pattern we have to see. This breathing pattern means what? How the patient is breathing, right? This is normal inspiration, expiration. This is your normal tidal volume, like that it is going on. This is known as what? Eupnea. Tachypnea means, tachy means fast, tachypnea means faster breathing, bradypnea means slower breathing, right? Apnea is going to be there. This Biot's breathing, where do you find this Biot's breathing? Remember, this is something you will be finding in the neuronal damage. It is something you will be finding in the neuronal damage, right? This hyperapnea can be there. You can have faster breathing, you can have deep inspirations can be there, right? This Kussmaul breathing is going to be something patient will be doing like that. This is going to be what? Kussmaul breathing. It is classically seen in the patients of diabetic ketoacidosis, right? He will be doing hyperventilation just to remove out the excess of CO2 that is going to be there, right? This is going to be Kussmaul breathing. Bradypnea can be there. You can have what? Chain strokes breathing pattern. This type of breathing pattern, gradual. Here you will be having normal, then you will be having what? Hyperapnea will be there, then there will be a period of what? Apnea. This is going to be increasing. One period of hyperapnea, then there will be a period of apnea. This is going to be chain stroke breathing pattern seen in the CHF. In the CHF you can find this type of breathing pattern, right? You can have air trapping in the cases of what? In the cases of emphysema, right? So this thing can happen, right? This apneustic breathing pattern you will be finding in the cases of stroke. Apneustic breathing pattern is going to be seen in the cases of stroke, right? So these are some important points that you need to remember about the different kind of breathing pattern. Now about the surfactant, because surfactant is going to be produced from, they have asked this question at least 3 to 4 times, right? It is going to be produced from which cells, from which part of the cells this is going to come out, right? Type 1 or type 2 pneumocytes. Your answer will be type 2 pneumocytes. Surfactant is produced from type 2 pneumocytes, right? This is going to be made up of what? This is going to be made up of 70% will be what? Phospholipid. What is the name of the phospholipid? That is going to be dipalmitoyl phosphatidylcholine, also known as lecithin beta, also known as lecithin. And the minor, this is the major component. Minor component of the same thing is going to be what? Minor component is, very good, this is going to be your sphingomyelin. And can you appreciate, we can do a ratio for this particular thing, right, to identify what, if the lecithin sphingomyelin ratio is coming out to be more than 2, this is going to be suggestive of what, fetal lung maturity, right, fetal lung maturity. This is just a lipid, right, it is a phospholipid in fact, right. So whenever there is deficiency, we can give steroids to the patient, and these steroids have a side effect of hyperlipidemia, so we can use dexamethasone or betamethasone, that you have studied in your OB-GYN, dexamethasone or betamethasone, right, dexona or betamethasone. It will be having a protein, major protein is going to be surfactant protein type B. We have got surfactant protein A, B, C, D. The major protein is going to be what, surfactant protein type B. The production of surfactant will start, the production will start at the 20th week beta, and maximum you will be finding this at the level of 34th week, right. If you have decrease in the surfactant, you can have a disease in the baby, that is going to be what, neonatal respiratory distress syndrome, you can call it hyaline membrane disease, right. You can also give surfactant from the outside, you can give what, intratracheal surfactant injections, you can give intratracheal even after the birth, you can give intratracheal surfactant, right. This is something we can also use from outside, right. So these are the some important points about surfactant, very important entity, right. Now try to tell me the answers of this question. Surfactant is going to be released from which cells? Answer will be yes, that is going to be your type 2 pneumocytes beta, type 2 pneumocytes, right. Cyanide poisoning causes which type of hypoxia? Histotoxic hypoxia, stagnant hypoxia, hypoxic hypoxia, circulatory hypoxia. Which type of hypoxia? Cyanide poisoning. Remember, histotoxic hypoxia, histotoxic hypoxia. In DK, what kind of pattern you will be finding? Patient will be rapidly breathing, right, deeply rapidly breathing, that is going to be known as what, Kussmaul beta, Kussmaul's breathing pattern, Kussmaul breathing, right. HbF will lead to what side of the oxygen dissociation curve? It is not going to get dissociated. HbF has got high affinity, so this is going to be going to which direction, right or left? Very good, this is going to go to the left, shift is going to be there, right, left shift is going to be there. Functional residual capacity involves what? It is going to include what? FRC is going to have what? Remember the mnemonic, Reti TVI, Reti TVI, right? So functional residual capacity will be having what? Residual volume, and expiratory reserve volume is going to be there. This is going to be the FRC, right? Again, if you want to ask you about the IC, this is going to be EC, tidal volume plus expiratory reserve volume is going to become what? Expiratory capacity, okay? Now, the next thing we are having is about the endocrine system, right? Total how many hormones are going to come out of the hypothalamus? These are going to be your thyrotropin releasing hormone, your oxytocin, your gonadotropin releasing hormone, your growth hormone releasing hormone, your vasopressin, CRH, somatostatin, and one more is going to be there. What is the name of that? That is going to be your dopamine beta, dopamine. So these 8 hormones are going to come out from here. 4 of them are going to be stimulatory. These are TRH, GnRH, GHRH or CRH. They are stimulatory. 2 of them are going to be inhibitory, your dopamine and somatostatin. Dopamine is also known as prolactin inhibitory hormone. And 2 of them are going to be VO hormone, V and O. V for vasopressin beta, V for vasopressin, also known as antidiuretic hormone, and O for oxytocin, O for oxytocin. These VO hormones are formed in the hypothalamus, right? So 4 of them are going to be stimulatory. These 4 are going to be what? Stimulatory. These 2 are going to be what? These 2 are going to be inhibitory hormones, and these 2 different hormones, they are formed in the hypothalamus. They are stored in the posterior pituitary. Very important concept. They are stored in the posterior pituitary, right? Posterior pituitary does not make any hormone. It does not make any hormone. If they ask you posterior pituitary makes which hormone? No hormone. Posterior pituitary stores which hormone? VO hormone, right? V for vasopressin, O for oxytocin, right? Now look at the pituitary gland. We have got this pituitary gland, we have got hypothalamus. Everything will be coming to the anterior posterior pituitary. This posterior pituitary will be having which hormone, beta? You already know this is going to be having what? Wo hormone, vasopressin and oxytocin. Oxytocin is a 4-time asked question in your FMG examination in the last 5 years, right? Very important. This oxytocin is something which is going to work on two important things. One is going to be in the breast. In the breast, what this oxytocin is going to do? This oxytocin is going to do milk formation or ejection. Very important. This is going to do milk ejection. In uterus, it is going to do what? Uterine contraction, right? If it is doing uterine contraction, what will happen to the, what will happen, how we can use this thing can be used for the induction of labor, also, and the same thing can be used for the PPH also. In fact, this PPH, the drug of choice, is going to be what? This is something we can use, right? The first line we can use, that is going to be what? Oxytocin only. So these two things for oxytocin is sorted, done, right? Vasopressin is also known as ADH, anti-diuretic hormone, will be going to the kidney lower part of the collecting duct, going to make what? V2 receptor, and this V2 receptor are going to make what? These V2 receptors are going to make what? They are going to make aquaporins. They are going to make what? Aquaporins. And this aquaporins are going to do what? These aquaporins are going to do what? They are going to do water resorption. They are going to do what, beta? They are going to do water resorption. They are going to resorb the water, right? So they are responsible for the water resorption. What about this anterior pituitary hormones? These are going to be what? These are coming out of the anterior pituitary. We have got growth hormone, we have got prolactin, we have got LH, FSH, ACTH and TSH. So all these hormones are coming from the hypothalamus. 4 hormones are coming from the hypothalamus. They are coming to the anterior pituitary. From anterior pituitary, all these things are going to come out, right? Remember, this prolactin is responsible for what function? This is responsible for the production of milk. This is responsible for the production of milk. Production of milk is due to what? And prolactin, right? And ejection of milk is due to what? Ejection of milk is due to oxytocin, right? This thyroid hormone TRH is going to come out from the hypothalamus, beta. This is going to activate anterior pituitary, and now anterior pituitary will release TSH, and this TSH will go to thyroid gland, and now this thyroid gland will be making what? T3 and T4, and now this T3 T4 will be coming into the blood supply, right? Anytime you have problem with the thyroid gland, this is going to be considered as the primary disease. Anytime you have problem in the anterior pituitary, this is considered as the secondary disease. Anytime you have problem in the hypothalamus, this is considered as the tertiary disease, right? So we have got primary, secondary and tertiary disease like that, right? So this is going to be the thing we are having, right? About this estrogen, progesterone, they are coming under the influence of LH and FSH. ACTH is going to make what? Adrenal cortex. It will go to the adrenal cortex. It will make cortical hormones. We'll discuss what are those cortical hormones, right? So these are some hormones which are coming from the pituitary, and they are going to do the functioning in the different parts, right? Now about the secondary messenger, we have got certain messengers. These are secondary messengers, right? We have got the cyclic AMP, we have got IP3-DAG system, we have got cyclic GMP and tyrosine kinase receptor, right? So these are important ones. Cyclic AMP is going to activate your GPCR, right? GPCR, and which subunit is going to be there? That is going to be GS subunit. Okay, cyclic this IP3-DAG is going to activate your GQ subunit, which is going to increase what? Calcium, and calcium has got 3 functions. We already know function of calcium. It is always going to do 3 function. In muscle, it is going to cause muscle contraction. In vessel, it is going to cause vasoconstriction, and in cell, it is going to cause what? Exocytosis. Exocytosis with the help of which protein? For exocytosis, which proteins are responsible? Yes, smear proteins. Very important, right? So this is going to be what? This is GQ subunit. Remember, ADH via V1 receptor, it is going to cause vasoconstriction. Angiotensin 2, it is going to cause vasoconstriction, right? Oxytocin is going to cause contraction in the breast and uterus, right? And this TRH is going to get contracted, and this is going to further cause the changes, right? So all these things are going to be working via which receptor? GQ subunit, or calcium is going to get there, right? Second thing is going to be what? Cyclic GMP. This has been asked previously in the examination. ANP and nitric oxide. Cyclic GMP, always remember, they will activate your nitric oxide pathway. Nitric oxide is always a dilator, right? Vasodilator. It is going to dilate the vessel, it is going to relax the muscles, right? So this is going to be what, causing what, vasodilatation, right? And this tyrosine kinase receptor, they are going to be responsible for the growth factors and insulin, right? This is going to be platelet derived growth factors, your epidermal growth factors, and insulin working via which receptor? Tyrosine kinase receptor. And in pharmacology, you learned about some drugs, which are the drugs which are ending with the nib. These are the drugs, they are going to be tyrosine kinase inhibitor drugs. In certain cancers, we look for the genes. If they are they are having tyrosine kinase activity, EGFR positive, we can understand this is EGFR positive. We can give what, nib life of drugs, right? For example, someone is having lung cancer, we can give what, we can give Jeftinib to the patient if he is coming out to be positive for this tyrosine kinase receptor, right? So this is about the secondary messengers, right? Secondary messengers are important. The next thing we are having is about the adrenal gland, right? Examiner has given this picture and he has asked which thing will be coming out from this particular part, right? So you need to understand, we have got three important parts. We have got basically two important parts. This gland is known as what, adrenal gland. And adrenal gland has got two important parts. One part is known as cortex, another one is known as medulla. The outer part is going to be what, cortex, and the inner part is going to be what, medulla. This is your cortex and this inner part is going to be what, medulla, right? In cortex, we have got three layers. These are going to be your zona glomerulosa, zona fasciculata, zona reticularis. We have got three layers: zona glomerulosa, zona fasciculata, zona reticularis. This fasciculata and glomerulosa is responsible for mineralocorticoid, fasciculata is responsible for glucocorticoid, and reticularis is responsible for androgens, right? Mineralocorticoid is going to be what, this is going to be your aldosterone, glucocorticoid is your cortisols, and these are your androstenediones, right? Aldosterone, you need to remember what aldosterone will do. It will go to upper part of collecting duct, making which channels? It is going to make your E-neck channel. And E-neck channel, epithelial sodium channel, you remember sodium is going to come inside. Who is going to follow? Sodium. This is going to reabsorb what, sodium and water. And if it will reabsorb sodium and water, what will happen to the BP? It will increase the BP. Sometimes you have increase in aldosterone, that would lead to what, Conn syndrome. So what happens in Conn syndrome, you can easily understand, right? This is going to have what, hypertension will be there in the patient, right? This is going to be aldosterone, right? What about this adrenal medulla? Remember, this medulla is going to release what, catecholamines, and these catecholamines are going to be what, your epinephrine, norepinephrine, and dopamine, right? These are going to be catecholamines. And if you have tumor of this adrenal medulla, that is what is known as what, pheochromocytoma, right? We learned about certain drugs. You have studied about what are the drugs you will be using here. You can use what, phentolamine, phenoxybenzamine. This has been asked in the last FMG exam, phenoxybenzamine, right? Phentolamine and phenoxybenzamine. This is for the pheochromocytoma. You can check for the plasma metanephrine levels. You can get the light bulb appearance. All these things are going to be there, right? Metanephrines. So this is going to be what, this is going to be pheochromocytoma, right? The next thing we need to remember is about the parathyroid hormone, calcitriol and calcitonin. This PTH is going to do what? Remember, this PTH is going to do, it is going to activate your osteoblast, and that osteoblast is going to activate your rank ligand, and rank ligand is going to activate what? Osteoclast, and this osteoclast is going to do what? Bone resorption. That means it is going to break the bone into calcium and phosphate. It is going to break the bone into calcium and phosphate. This is the function of what? This is the function of parathyroid hormone, right? Now this PTH is going to do what? It is going to have stimulus, decrease in serum calcium. It will break the bone, it will increase the serum calcium. Increase in serum phosphate, it is going to have opposite effect in phosphate. It is going to increase the phosphate also. It is going to increase the calcium and phosphate by breaking the bone. But when it will go to the kidney, it will reabsorb the calcium and it will kick out what? It will kick out the phosphate. It will decrease the phosphate reabsorption. So any which ways, whenever you are going to have increase in serum phosphate or decrease in calcium, it will break the bond. It will bring out both the things, calcium and phosphate, and then it will send this phosphate out of the urine, whereas it will reabsorb the calcium. This is how this thing is working. Net effect is going to be always it will increase the serum calcium and decrease the serum phosphate. Calcitriol, also considered as vitamin D3. Vitamin D3 is responsible for the increase in the or it is going to be helping in the calcium reabsorption, calcium as well as phosphate reabsorption. It will increase calcium as well as phosphate. In both the condition, net effect is going to be what? It will increase calcium and phosphate. What are going to be stimulus? Decrease in serum phosphate, decrease in serum calcium, or maybe increase in parathyroid hormone will also lead to what? Activation of this vitamin D3. What about this calcitonin? Calcitonin, whenever you are having increase in serum calcium, it will decrease the serum calcium, right? It will do what? It will decrease the resorption of the bone, right? It will decrease the bone resorption. It will prevent the bone from breaking, right? And it will increase the excretion of extra calcium or phosphate that is present in your blood, right? So anytime you have increase in serum calcium, it will decrease the serum calcium. Second thing, it will stop the bone resorption. If someone is having bone resorption, we can give calcitonin spray also, right? This is going to prevent the bone resorption, right? Now some hormones that you need to remember. Look here, certain points that you need to remember. These are all the hormones, these are all the functions, right? You need to remember this prolactin release is going to be increasing by suckling, by TRH, by sleep, by sex, right? These are the things which are going to increase what? Which are going to increase what? Prolactin levels, right? Growth hormone will also increase by exercise, hypoglycemia, GHRH. These are the things which will increase the growth hormone, right? For oxytocin, you need to remember about the cervical stretch, and suckling is going to be important, right? This insulin is going to be increased in the cases of hyperglycemia, and who is going to increase insulin further is going to be what? Incretin. This incretin is also going to do what? Increase in the insulin levels, right? This is how you need to remember basics, right? Now about synthesis of vitamin D, right? The synthesis of vitamin D is going to take place in which layer of the skin? This is going to be your Malpighian layer. Malpighian layer. What is this Malpighian layer? This is going to be what? The lowermost two layers, that is going to be stratum spinosum plus the stratum basal. Both of them are together known as what? Malpighian layer. So this thing is going to be responsible for the production of vitamin D. Now what will happen? You will be having 7-dehydrocholesterol, which will convert into what? Cholecalciferol, and you can also directly have this cholecalciferol from the fish products, right? What is the fish which is having this particular maximum amount of this particular thing is going to be what? Halibut you can have, right? This thing can be there, right? Now this cholecalciferol will go to the liver, and it will be having first hydroxylation at 25th position. 25th position you will be having first hydroxylation. This is known as what? Now it is going to convert into, this is your D1. Now it is converted into D2. This is your vitamin D2. First it was cholecalciferol, now it is 25 hydroxycholecalciferol. Again it will go to the kidney, and in kidney it will be having again hydroxylation at the first position, and now it will become what? Now it will become 1,2,5 dihydroxy. Now it will become what? 1,2,5 dihydroxycholecalciferol, which is also known as vitamin D3, which is also known as calcitriol. These are all the same name for the same thing, right? This is going to be what? Calcitriol. 1,2,5 dihydroxycholecalciferol, or also known as what? Calcitriol. So this is going to be the thing we are having. This question has been asked previously, you have to remember this, right? Now the one liners that we are having. Leydig cells are going to be responsible for the release of, Leydig cells are going to release what, beta? Leydig cells are going to release what? Under the influence of LH. Under the influence of LH, this Leydig cell is going to release what? Testosterone. Testosterone. And this is the testosterone in child, in the earlyhood, it is going to produce what duct? Wolffian duct. It is going to make which duct? Wolffian duct. Second thing is going to be erythropoietin is secreted from where? What is the location? This is going to be your peritubular capillaries. Peritubular capillaries. Oxytocin is going to come out from which part? It is secreted from where? It is secreted from where? It is formed. If they ask you it is formed where, this is going to be O hormone. Remember, it is formed in the hypothalamus. Hypothalamus. It is getting stored in the posterior pituitary, but it is stored in the posterior pituitary. Remember, O hormone, vasopressin and oxytocin. Examiner favorite oxytocin and surfactant question. Very, very important. Multiple times asked the same question. Thyroid binding, thyroid hormone will bind with the major globulin is going to be what? Thyroid binding globulin. Thyroid binding globulin. The major globulins are going to be what? Thyroid binding globulins. They can bind to your beta receptors, also leading to what? Increase in heart rate, conduction, your contraction, right? This thing can also happen. What is the action of PTH on calcium? Calcium, PTH, what is going to be the role? This PTH is going to do what? Bone resorption. It is going to do what? Parathyroid hormone will do bone resorption. It will increase the serum calcium. It will increase the serum calcium. It will decrease the serum phosphate, right? This is the role of this PTH. Nitric oxide is going to get synthesized from which amino acid, beta? This is going to be what? This is synthesized from the arginine. This is synthesized from the arginine, right? Which amino acid is going to synthesize what? Melanin. Melanin, T3, T4, epinephrine, norepinephrine, dopamine. Now I know you must have guessed it, right? This is going to be what? Tyrosine, beta. Tyrosine is the amino acid for this particular thing, right? Tyrosine, right? Histidine is going to release what? Histidine is going to make what? Histamine. For histamine, we have got what? Histidine, right? So these are the amino acids we are having for some important functions, right? Alright, now we will be discussing about the excretory system. What are the important things that you need to remember about excretory system? We already know the cardiac output is going to be what? Cardiac output is the amount of blood that is coming out of the heart, right? That is known as cardiac output, right? Cardiac output is equal to heart rate times stroke volume. We already know what is stroke volume. Out of that 120, how much is left in the body itself? How much is left in the heart itself? That is 50. So 70 is going out. That is known as stroke volume, right? So 70 times 70 is going to be somewhat around 5 liter, right? So that is going to be the cardiac output. Now out of that 5 liter, how much is going to the kidney? This is known as what? Renal blood flow. So how much is going to the kidney? That is 20% of 5 liter. That is going to be 1 liter is going to the kidney. Out of that 1 liter, beta, remember renal plasma flow. So 1 liter blood will be having what? 60% plasma. So 600 ml plasma will be there, right? So 600 is the renal plasma flow, and out of that 20% of 600 will be getting filtered, and that is going to be 120 ml. This is going to be what? GFR. This is going to be glomerular filtration rate. So simply, if you want to see, this is your heart. The blood will be going 5 liter. Out of that 5 liter, 1 liter will be going to the kidney. Out of that 600 ml is going to be the plasma, and this is the plasma which is entering into the afferent arteriole. And after that, how much is getting filtered is known as glomerular filtration rate. So how much is getting filtered? Again 20% of 600, that is going to be 60, and 60 120. So this is going to be what? GFR. This is GFR, and efferent arteriole will take up the blood again, right? Now what are the parts of this particular nephron? The first part is proximal and convoluted. This is known as proximal convoluted tubule. Whereas the next part is going to be what? This is your loop like structure. This is your hairpin like structure. This is known as loop of Henle, where you will be having what? Sodium potassium 2 chloride pump, right? The next part is again distal, and this is again convoluted. This is known as what? Distal convoluted tubule. Distal convoluted tubule. And lastly we have got what? Lastly we have got the collecting duct. In collecting duct we have got upper part and lower part of the collecting duct. Upper part will be having aldosterone, lower part will be having what? ADH will be there, right? So this is going to be the structure of the nephron. This is going to be the structure of the nephron, and all this nephron is going to drain into ureters. Two ureters are going to drain into bladder, right? This is going to be something coming into the bladder, and out of that you will be having what? Urinal. You will be having coming out of urethra, and that urethra would be going to the urinal, right? So this is going to be the structure. This is going to be the story. But you need to remember what is the normal urine output. That is going to be 1.5 liter, 1500 ml per day. That means in 1440 minute you are going to make what? 1500 1500 ml of urine, right, in one day. So that is going to be 1 ml per minute. Can I say like that? Yes, right? So that is what we are going to make in a day, right? 1 ml per minute. Out of this 5 liter blood, we are only making how much urine? 1 ml per minute. And this is a very efficient system we are having. So let's try to understand how this efficiency is going to get achieved, how other things are going to get reabsorbed. Examiner is fond of asking questions from this particular diagram. You need to understand very simply, right? So remember, 65% of the water is going to get reabsorbed in the PCT itself. So maximum reabsorption in the PCT itself. Second thing is your glucose, your amino acids. 100% of glucose and amino acids are going to get reabsorbed in the PCT itself, right? This loop of Henle will be having which pump? Sodium potassium 2 chloride pump. Sodium potassium 2 chloride pump is going to be responsible for 25% of the salt reabsorption. DCT will be responsible for 6 to 8% of the salt reabsorption, and the collecting duct will be responsible for 2 to 3% of salt reabsorption. So this is how this system is going to reabsorb 99% of the things, right? So these are the places where you can use your drugs also. These are the places, these are the points you have to remember, right? Another question they are asking about the magnesium. The magnesium, you have to remember, is going to get reabsorbed maximally in which pump? Sodium potassium 2 chloride pump. This is going to be sodium potassium 2 chloride pump. In fact, you need to remember about this chloride also. Sodium and chloride should be coming here, but sodium will travel with glucose and other things. So what will happen with the chloride? It will travel here and it will get reabsorbed here. This is going to be what? Sodium potassium 2 chloride pump, right? Here you will be having DCT with sodium chloride pump, right? Upper part of the kidney will be having what? Aldosterone. We have seen aldosterone is coming from the adrenal gland. Which part of adrenal gland? That is going to be cortex, and that is going to be glomerulosa, zona glomerulosa. And it has got a function. Aldosterone is going to make what? E-neck channel, epithelial sodium channel, which are going to do what? Reabsorption of what? Water and salt, right? Leading to increase in the BP. This is going to be the story of aldosterone, right? Whereas antidiuretic hormone, I told you, two hormones are formed in the hypothalamus, but they are stored in the posterior pituitary. What are those hormones? Wo hormones, vasopressin and oxytocin. What are those hormones? Vasopressin and oxytocin, right? And this vasopressin is also known as what? This vasopressin is also known as antidiuretic hormone. This is the same hormone, and this vasopressin is going to make which receptor? V2 receptor, which is responsible for the production of what? Aquaporins, right? Aquaporins. So more V2 means more aquaporins, less V2 means less aquaporins, right? And you can also appreciate some diseases along with this, right? If you have increase in the aldosterone, what thing can happen? Increase aldosterone can lead to Cone syndrome, right? Decrease in aldosterone is something you will be finding with the Addisons. If you have increase in ADH, this is going to be what? Syndrome of inappropriate antidiuretic hormone, which is treated with the conivaptans, right? Vaptans groups. And decrease in ADH is going to be what? This is known as what? Diabetes insipidus. Diabetes insipidus, right? So these are the some identification that you should be having, right? These are some common things you should be remembering about this particular thing, right? They have asked questions on the glucose, 100% of glucose, that is going to be with the SGLT pump. You can also remember the drugs here. You can use carbonic anhydrase inhibitors in PCT. You can use loop diuretics in this particular sodium potassium 2 chloride pump. You can use what? In DCT, you can use which drugs? These are going to be your thiazide group of drugs. And lastly, in the collecting duct, you can use what? Potassium sparing diuretics. They are going to be working over here, right? So all the drugs also you can remember with the help of this particular diagram, right? You can also have certain syndromes. 3 syndromes you have to remember. The first one is going to be what? First one is going to be your Bartter syndrome. Bartter syndrome is due to mutation in sodium potassium 2 chloride pump. Second one is your Gitelman syndrome. Gitelman syndrome is due to mutation in your sodium chloride pump that is present on the thiazide pumps. And third one, if there is mutation of E-neck channel, E-neck channel mutation will lead to a syndrome known as Liddle syndrome. And this Liddle is a gain of function mutation where you will be having increase in BP, hypertension, all those symptoms are going to be there, right? So this is going to be what? These are the syndromes that can happen because of this thing, right? So this is something you need to remember. Now about the regulation of GFR beta. Simple understanding, GFR regulation, we already know heart will be releasing everything. It will be coming to the afferent arteriole, then it would be going to the efferent arteriole. It will increase renal blood flow, and here you are having GFR, right? So this is the basic thing, and here whatever is going to get filtered is known as what? GFR, right? Now we will discuss what prostaglandins will do. Remember, simple understanding, prostaglandins will decrease the afferent arteriolar resistance. This part is going to get dilated. So what happens? More blood flow will be there, RBF will be more blood flow means more filtration will be there, GFR will also be more. In fact, this norepinephrine, we already know what norepinephrine will do. It is going to increase the BP. How it will increase the BP? It will remove the water from the body, or it will absorb the water? Yes, it will absorb the water, right? So it will cause what? Increase afferent arteriolar resistance. It will constrict this part, leading to decrease in the blood flow to the kidney, decrease in GFR to the kidney. It will also, like we can think about ACE inhibitors also. This ACE inhibitor decrease efferent arteriolar resistance. So this part will be dilated. What will happen now? More blood flow will be there, leading to increase in GFR. Angiotensin 2, this is also going to do what? This is going to increase the efferent arteriolar resistance. This is going to cause what? This is going to constrict this part, and because of that, what will happen? Angiotensin will also lead to increase in the BP by decreasing what? By decreasing the urine output, by decreasing the GFR, by decreasing the renal blood flow, right? So this is how it is going to happen. The next thing is about the cystometrogram beta. Cystometrogram is the graphical representation of your bladder, right? So what happens in your bladder? You will be having like 400 to 700 ml of capacity of your bladder. What happens after micturition? When you urinate, what happens after that? Let's try to understand. We have got 1A, we have got 1B, and we have got 2. These are the 3 stages that we are going to have. So remember, can you appreciate this is a pressure volume graph? So on the y-axis you will be finding the pressure, on the x-axis you will be having intravascular volume will be there, right? So here you will be having, can you appreciate, in 1A you are having increase in the pressure and increase in the volume also. So 1 is going to have what? Increase in pressure will lead to what? Increase in volume, right? Second thing is going to be 1B. Now you need to appreciate here, this 1B is going to be a phase which is going to be a very long phase where you will be having increase in the volume. The bladder is getting full, but yes, we do but yes, we do not have increase in the pressure, right? Because pressure remains constant, right? So increase in volume, pressure is going to be what? Constant, and there is increase in volume. This is known as what? This is known as a law, and this law is known as what? This law is known as Laplace law. This law is known as Laplace law. So because of this Laplace law, what is happening there? This is going to explain us this particular thing. That means pressure remains constant, but the volume is increasing, right? And this phase 2 is going to be telling us about what? Phase 2 is going to be what? Now you will be having tremendous increase in the pressure. You will be having marked sensation, and now you need to go for what? Urination. Here you will be having increase in the pressure, and now you need to go for what? Urination. Micturition will be there. Retrosal muscle will get contracted. You will be having opening of internal external sphincters, and you can go for urination. This is what is cystometrogram, right? The examiner has asked about this graph, and what is this 1B is indicating? Simple understanding, we can answer this, right? Now try to solve this one-liner questions. Renin is coming from which cells beta? Renin is going to come out from which cells? We have already answered this question. Renin is coming from which cells? Yes, renin is coming from the JG cells of kidney. JG cells of kidney, right? These are going to have some smooth muscle cells which are going to release this renin, right? Okay. Erythropoietin is coming from which cells? This is also, we have seen, peritubular capillaries. This is going to come out from peritubular capillaries. Glucose and amino acid absorption in kidney is going to be taken place at PCT and 100% of glucose and amino acid. Very important question. What is the function of atrial natriuretic peptide? We have seen ANP is going to do what? It is going to cause what? Natriuresis. Natriuresis means what? Natriuresis means it is going to throw what? Sodium out. If sodium will be out, who is again going to go out along with it? That is going to be water. And if it is going to let the sodium and water go out, what will happen to the heart? The pressure will be decreased. This is coming from the walls of atria, atrial natriuretic peptide. So whenever there is increase in pressure, it will cause what? Release of this thing, which will decrease the pressure. 1B in cystometrogram is going to be based on which law? 1B is going to be based on, yes, that is going to be Laplace law. Very good, that is going to be Laplace law. Bartter syndrome is due to mutation in, this is going to be due to mutation in which gene? That is going to be what? Sodium potassium 2 chloride pump mutation will lead to which syndrome? Bartter syndrome. An impaired function of aquaporin is known as, impaired function means decreased functioning of aquaporin. If there is decreased functioning of aquaporin means what? Who is going to be less? Aquaporins are synthesized from V2 receptor EDH, and this disease is known as what? Diabetes insipidus. This is known as diabetes insipidus, right? We have two types of diabetes insipidus. If it is central, if it is nephrogenic. In central, we give drug of choice, that is going to be desmopressin. In nephrogenic, we give drug of choice, that is going to be thiazides, right? Now, about the reproductive system, one thing you need to understand about this hormonal action, we have seen hypothalamus is going to release 4 stimulatory hormone. One of them is going to be what? GnRH, gonadotropin releasing hormone. And this gonadotropin releasing hormone will go to the anterior pituitary. It will release what? FSH and LH, follicular stimulating and luteinizing hormone. This LH will go to Leydig cell, we have seen, and Leydig cell will make what? Testosterone, and this testosterone is responsible for the generation of internal genital organs. It will go to Sertoli cells also, right? Now, what Sertoli cells will release is important. This is going to be what? Inhibin, your previous year exam question. This inhibin is going to be responsible for negative feedback to the anterior pituitary. Inhibin, name itself suggests that it is going to inhibit something, right? So this is going to be inhibiting what? Anterior pituitary. Hormonal actions are important, but hormonal actions for estrogen and progesterone, they are asking. Estrogen has got some important functions, like if you talk about a breast, right? Breast will be having these ducts, and these lobules are going to be there. Breast will be having what? Ducts are going to be there, and these lobules are going to be there along with the subcutaneous tissue, right? This is going to be what? This is going to be the structure of breast, right? This is going to be an opening into nipple areola, right? So this is the basic structure of the breast, right? Now you need to understand in the breast what is going to be the development. This ductal growth is due to what? This ductal growth is due to what, beta? This is due to estrogen. So more estrogen means more ductal growth. If someone is having what? Ductal carcinoma, we want to remove the estrogen so that this cancer will not get increased, right? Second thing, increase in cervical mucus, it is going to allow for the reproduction. This is going to be there, right? It will increase the epithelial proliferation and lubrication also, right? It will be helping in the bone density maintenance also. What about progesterone? Progesterone is a secretory hormone. Second half of the cycle will be there. It is responsible for lobular growth, beta. Lobular, very important, right? It is responsible for lobular growth, and it can thickens the cervical mucus so that other things will not enter, right? It will raise the basal body temperature also. It will increase the basal body temperature. It is a CNS depressant, you need to remember. So till the time you have what? You have progesterone in the body, like a second half of the cycle, female will be having what? Progesterone. Till the time you have progesterone, what will happen? The brain will be depressed, right? Brain will be fine. As soon as you have loss of progesterone, now what will happen? Now you will start to have irritation. Now you start to have what? Symptoms, right? Whatever symptoms, okay? Mood swings, everything is because of this progesterone. The same thing you can apply in the pregnancy as well, right? In pregnancy, what happens? The female will be in the progesterone throughout their cycle, right? As soon as she will be having what? Delivery. Now what happens? Loss of progesterone. Loss of progesterone means what? Now she can have problems like you read in psychiatry, like postpartum blues can be there, postpartum psychosis, postpartum depression can be there, right? So this thing can also happen due to abrupt loosening of this progesterone. This thing can also happen, right? So these are the things. Now try to solve this one liners that we are having. What is the effect of estrogen? The effect of estrogen in the bone. In the bone, it is going to be stimulatory, right? The effect of estrogen in the breast, it is going to be responsible for which growth? For the ductal growth. Ductal growth. right? FSH surge is going to indicate what? Like LH surge is responsible for what thing we already know, for ovulation, right? But this FSH surge is going to be responsible, it will increase what? It will increase plasmin, and this plasmin is going to rupture the follicle in the ovary. It is going to be responsible for the lysis of the follicle, lysis of follicle. And due to that, what will happen? This secondary oocyte is going to come out, which we call it as an egg, right? Which is picked up by the Fimbrias. That is going to be secondary oocyte, right? Now, Klinefelter syndrome is a male person or a female person? Klinefelter is going to be what? 47XX5 is going to be what? This is going to be a male person. Remember, whenever you see Y chromosome, this Y chromosome is present on SRY gene, right? This is going to be coming in the life in 6th week of intrauterine life, 6th to 7th, right? If you have SRY region, that is going to be, you are going to become a male person. Otherwise, any which ways you are going to become what? Female. By default, you are always going to become what? By default, you are always going to become a female person, right? Turner is going to be what? 45XO. Now this is going to be a male or a female? XO. There is no Y. If there is no Y, this person is going to become a female. About the sperm pathway, the sperm is going to be formed in the testes, beta. Where exactly in the testes, if you want to know, that is going to be your seminiferous tubule, seminiferous tubule. And through seminiferous tubule, it will be going where, beta? It will be going to the epididymis. Epididymis for what purpose? For the storage, for the storage and maturation purpose. And after this epididymis, it will go to vas deferens. Vas deferens, it will be coming to seminal. Seminal vesicle will drain the seminal fluid, and prostate will drain the prostatic fluid, right? Both the things will be coming, and now this thing is known as what? Now this thing is known as semen. Vas deferens will be having approximately 10% of the sperms will be there. Then it will be binding with the seminal fluid, it will be binding with the prostatic fluid. Now it will become what? Semen. And this semen will enter into female genital tract, and it will be getting maximum motility. This is known as what? Capacitation. Capacitation means maximum motility, and this thing is going to take place in the female genital tract. Female genital tract, right? This is going to be what? Capacitation, beta, right? So this is going to be the pathway for the sperm, pathway for the sperm, right? The next question we are having is about the motility in the GIT segment, right? The first motility that we are having is known as what? BER. These are the BER, basal electrical rhythm. Suppose it is going to given like one contraction is happening in the 10 second. Now you need to identify the location. What is going to be location? This spike potential are due to acetylcholine M1 receptor, right? Acetylcholine parasympathetic nervous system we have seen, right? So 10 second there is going to be one contraction. So in a minute, how many contraction can be there? This is going to be what? How many waves can be there in a minute? This is going to be what? Sigmoid. So this is what they have asked. They have given this picture. Instead of 10 second, if I write you like this 5 second, what is going to be your answer? What is going to be your answer? If one contraction is in 5 seconds, how many contraction will be there in a minute? In a minute you can have 12 contraction, and this is going to become what? Duodenum. So that means you can have 12 contraction in duodenum in a minute, right? That is how you can appreciate this thing. This is your electrical motility, basal electrical rhythm. Second thing is your mechanical motility, where you will be having what? This peristalsis. Peristalsis is what? Forward propulsion or forward movement of the food in this direction is known as what? Peristalsis. Here the posterior segment will get contracted, anterior segment will get relaxed, right? And the contraction of posterior segment is going to be due to two important things, that is going to be acetylcholine and substance P. Whereas relaxation of the anterior segment is due to nitric oxide and vasointestinal peptide, VIP. These are going to be responsible for the anterior relaxation. So superior part will be relaxed, posterior part will contract, and this is how this thing will move in the forward direction. This is what is known as what? This is known as peristalsis. This is known as what? Peristalsis. What happens in segmentation? In segmentation you will be having what? The same segment will contract, the same segment will relax, the same segment will contract and relax, and this type of movement will be happening on the same location. This is going to break down the big particles into smaller particles, and further mixing is also going to happen in the segmentation. Important motility is segmentation. right? You can also have MMC. What is migratory motor complex? MMC is going to be a strong wave of contraction, generating from which part? From mid part of the stomach, to terminal ileum, This is known as what? This is known as migratory motor complex, the voice that is coming in our stomach, right? When we are hungry, this thing will happen after every 90 to 120 minutes. This is known as what? This is known as migratory motor complex. Now some enzymes are important, some enzymes which are coming from the GIT. This gastrin is responsible for the increase in the release of HCl coming out from the G cells. The secretin, also known as nature's antacid, will increase what? Bicarbonate secretions. Cholecystokinin is going to release what? It is going to release pancreatic enzymes. This GIP is a type of incretin which will increase the release of insulin. Motility, just now we have seen, is going to activate your MMC, migratory motor complex, also known as broomstick of GIT, from the mid part of the stomach to the terminal ileum. Somatostatin is a universal inhibitor, is going to inhibit what? Gastrin, insulin and other things also. Histamine coming out from the ECL like cells, it will increase what? Acid secretion via which receptor? H2 receptors. Right? Now very important thing that we are having is about the iron absorption, right? Iron absorption, first question they are going to ask you, what form of iron you are going to eat. This is going to be ferrous or ferric. So ferric is going to be what? Fe3 plus C, you can remember, for 3 plus. Now this Fe3 plus will convert into Fe2 plus. This Fe3 plus will convert into Fe2 plus with the help of duodenal cytochrome B. Once this duodenal cytochrome B will convert it into Fe2 plus, this Fe2 can enter because divalent metal transport is there. So only the thing with the 2 valency can enter inside. So Fe2 plus or ferrous can get inside. Once ferrous can get inside, it can either store in the form of mucosal ferritin. The storage form is going to be what? Ferritin. Whereas extra thing is going to go into the blood vessel. This is going to be what? This is going to be mucosa, this is going to be epithelial cell, and here you will be having submucosa, which is having what? Blood vessel, right? This is how you need to orient yourself. Here you will be having food particles, here epithelial cells, and here you will be having submucosa with the blood vessels, right? So this ferroportin is going to allow the entry of this Fe2 plus. Once this Fe2 plus will come here, it needs to again convert into Fe3 plus, and this thing is done with the help of what? With a hephaestin. And this Fe3 plus, once converted, cannot travel alone. It requires what? Plasma transferrin, which is a transporter of iron, and this transferrin is going to transport this iron to the bone marrow for the production of what? Hemoglobin and RBCs, right? And another extra of this particular thing will go to the liver, and now liver will send a brake. What is the name of this brake? This brake is going to be what? Hepcidin, and this brake is going to put on the ferroportin, and it is going to stop the entry of iron into the blood, right? So it can stop. But if you have mutation of this particular thing, this is known as what? HFE gene mutation. This is known as what? Hemochromatosis. This disease is known as what? Hemochromatosis, where you will be having what? Bronze diabetes will be there. You can have liver cirrhosis can be there. You can have what? Hyperpigmentation can be there. All these things can happen, right, in the hepcidin mutation. So this is the basic story. They are going to ask you, iron absorption is going to get increased by your acids, right? By your juices like orange juice, right? It is going to get decreased by the, remember, sprouts has been asked previously, your tea has been asked previously, your coffee has been asked previously. So all these things are going to decrease the acid secretion, your phytates, your tannins, phytates, your oxalates. These are the things which are going to do what? Decrease in the acid decrease in the absorption. Other things are going to get increase in the absorption, right? So these things are important. Now about the substances and their primary site of absorption, what are going to be the sites, right? So they have asked the question on the iron metabolism, iron absorption. Just now we have seen happening in the duodenum. duodenal cytochrome B, duodenum, so you can remember duodenum. Folate, vitamin B9 is going to be generally duodenum and jejunum. B12 is going to be what? Terminal ileum. Very important question, has been asked multiple times, right? And mineral absorption, generally small intestine. Bile salt is entering into enterohepatic circulation. The function of bile is to do what? Emulsification of the fat, right? So this is going to be the important thing. Now try to solve these questions. Iron absorption is going to be increased by, this is going to be increased by vitamin C. In the question they have written what? Ascorbate, ascorbic acid, vitamin C derivatives or acids basically is going to increase the iron absorption. Next question is posterior segment in peristalsis is contracted by, contraction is due to two things. One is going to be acetylcholine beta, second one is going to be substance P, substance P. Two things are going to be there, acetylcholine and substance P. Which thing will decrease the acid secretion in parietal cell? Parietal cell will be having H2 receptor which will increase the acid. Gastrin will also increase the acid, right? You will be having what? You will be having acetylcholine coming from the M1 receptor, that is also going to increase the acid. The thing which is going to decrease the acid is going to be somatostatin. This is ionized question, has been repeated in Neet PG also. Somatostatin, along with that negative feedback, along with the negative feedback, both the things are going to be responsible for what? Both the things are responsible for decrease in acid secretions. Glucose absorption in intestine via which transporter? This is going to be your gut. Sorry, in intestine it is going to be SGLT. Glut is also going to be present, that is going to be GLUT2, right? Vitamin B12 is going to be absorbed from which part of the intestine? The answer will be what? Terminal ileum beta, terminal ileum. It is going to bind with the intrinsic factor vitamin B12 and will come to the terminal ileum, and there it will be getting reabsorbed, right? It will be getting absorbed in the terminal ileum, right? In musculoskeletal system they are going to ask you this particular question multiple times. They have asked the same question they are talking about, right? It's very simple. This is going to be what? This is going to be a Z line, this is another Z line that we are having, and the thing between these two Z line is known as what? Sarcomere. This blue color filament, this small thin filament, this is known as what? Thin filament, also known as what? Actin. This red color filament that you can appreciate is a static filament, this is going to be what? Myosin. The line which is going to contract this myosin from middle is known as M line. Myosin line is known as M line. Here you are having the spring like structure, this is known as what? This is known as titin. It is responsible for elasticity beta, elasticity, right? The band which is having what? Actin is known as what? I band. This is known as I band. The band which is having actin as well as myosin, this is known as A band. This is known as A band. Why do we call it A and I? I means isotropic. I means isotropic. Iso means same thing will be there. A means what? Anisotropic. And iso means different things are going to be there. Anisotropic will be having what? This is going to have what? This is going to have two things. It will be having myosin as well as actin. Both the things are together. This is going to be A band. This thing is going to have I band. Here you will be having M line. This thin filament is going to be actin. This thick filament is going to be myosin. The question they are going to ask you, what will happen during contraction? Both these Z lines are going to come closer. This myosin remains as it is, right? So what will happen? And the zone between these two M line is going to be known as which zone? H zone, right? This zone is between these two lines is going to be what? H zone, right? So this is going to be the story. So A band, what will happen? Myosin length stays the same beta, right? A band is not going to get decreased or increased, it is going to be the same. It is going to be the same, right? I band, they will come near. So what will happen? They are going to shorten during the contraction because both the things will come in the same direction. I have shown you the video also, right? H zone, what is going to happen? In H zone you will be having what? Myosin will be there. So H zone is going to get disappear, right? It will, both the things will come together, it will get disappear from here, right? This is going to be H zone, and Z line is going to be that this particular line is known as what? Z line. They will also come closer, right? Who is responsible for the contraction? This is going to be calcium. Here you will be having DHPR What kind of coupling will be there, that is also important. Dihydropyridine receptor plus ryanodine receptor coupling will be there, and this coupling will lead to opening of sarcoplasmic reticulum, which will increase what? Calcium. Which will increase what? Calcium. Remember, this is your Neet PG question. DHPR plus RYR coupling is not electrical coupling. This is going to be a type of mechanical change, is going to conformational change is going to take place. This is a mechanical type of coupling will be there, right? So this is going to be the thing, right? What is this disease we are having? This sign is a very classical sign. This sign is known as what? Go over sign, beta, go over sign. And this disease is known as Duchenne muscular dystrophy. Duchenne muscular dystrophy is due to mutation in which gene? This is going to be your dystrophin. Complete loss of dystrophin will lead to Duchenne muscular dystrophy, right? And partial loss of dystrophin will lead to what? Partial loss of dystrophin will lead to Baker's muscular dystrophy. Baker's muscular dystrophy, right? Complete loss will lead to Duchenne muscular dystrophy, right? Now about this presynaptic condition that we are having, whenever this action potential is going to travel, what will happen? This action potential, here you will be having what? Voltage gated channel. So as soon as it will sense the current, what will happen? Voltage sensitive calcium channels are going to be there. They will come into action, and they will send what? They will send this calcium inside. And we already know calcium has got three function: in muscle contraction, in vessel vasoconstriction, in cell it is going to do what? Exocytosis. So as soon as this calcium is going to come inside, what will happen? This vesicles which are already having what? Which are already having acetylcholine will come, and they will bind to the surface. They will be having snare protein, they will bind to the surface, and now they will be doing what? Exocytosis. Now these vesicles are going to release everything out, and this everything out is going to be what? This is going to be acetylcholine, which will go to the another membrane. This is the synapse, right? And here you will be having starting of the functioning. Postsynaptic membrane will start to have different functioning is going to be there. It can be neuromuscular junction also, it can be neuronal junction also, right? So 1 2 3 things we have to understand here. If you have mutation, of this particular pump, you will be having a syndrome. This syndrome is known as what? This syndrome is known as Lambert-Eaton syndrome. If you have mutation, if you have problem with this particular thing, this is going to cause what? This is going to cause a disease, myasthenia, right? If this acetylcholine receptors are not working, you can have what? Myasthenia gravis. If this action potential is not coming, you are blocking this action potential. This is action of what? Local anesthetics. They are blocking the sodium channel. If sodium channel are going to get blocked, do you think there will be transmission of the impulses? There will be depolarization of the cells? No, there will be no depolarization. There will be no transmission of the impulses will be there, right? So these are the syndromes that can happen, right? So let's try to answer. RYR mutation will lead to what? This will lead to malignant hyperthermia, beta. So when you have RYR gene mutation, it will lead to what? Increase in the sarcoplasmic reticulum, leading to increase in the calcium. You know, calcium will cause what? Vasoconstriction, muscle constriction, exocytosis. What happens in body? You will be having hypermetabolism state. That is what is known as what? Malignant hyperthermia, which is seen with succinylcholine, which is seen with any inhalational agent. And the treatment will be sodium dantrolene, IV sodium dantrolene, right? What happens during contraction? What happens to the H zone, beta? What happens to the H zone? What happens to the H zone? Try to appreciate this thing. During contraction, these things will come closer. This H zone will be increased or decreased or remains constant. Yes, very good. This is going to get decreased, right? It will get contracted. It will get decreased. It will get decreased, or it will get contracted. It will get decreased, or it will get contracted, right? What will happen due to mutation in voltage gated calcium channels at neuromuscular junction? This is going to cause what? Lambert-Eaton myasthenia syndrome. Lambert-Eaton syndrome is going to be there, right? Lambert-Eaton syndrome. Multiple sclerosis is due to mutation in which gene? What is going to be the problem? Here you can have problem with the myelin basic protein also, or you can have problem with the oligodendrocytes. Remember, one oligodendrocyte is going to do myelination of 30 neurons in CNS, right? Whereas one swan cell is going to do myelination of what? One single neuron. You can remember swan cell for single neuron in PNS, right? So this is going to be the problem with the multiple sclerosis, which is a central problem, and this is going to be a peripheral problem. Here swan cell problem, remember GBS patients are having, if there is mutation, if there is antibody against this swan cell, patient will be having which disease? That is going to be Guillain-Barré syndrome, treated with intravenous immunoglobulins, right? And this is going to be the thing we are having, right? Next thing is about the central nervous system. What are the important things you have to remember is about this particular mnemonic that you need to remember. This is the mnemonic we are having. This particular graph is known as what? This particular table is for the Erlanger and Gesser classification. What is this classification for? Remember, this Erlanger and Gesser classification is the classification for the nerve fiber. This is the classification for the nerve fiber. We have got multiple types of nerves, right? So we have got A alpha, A beta, A gamma, A delta, B or C, right? I told you the mnemonic is Prime Minister, pressurized to sign the contract fast, right? So Prime Minister is going to be A alpha is for the proprioception, for motor function. Pressurized means pressure and touch, that is going to be A beta, that is what is the basis for massage, right? This is going to be sign is going to be what? Muscle spindle. The contract fast is going to be touch, cold temperature, fast pain, right? And here B and C fibers are the slow fibers. What you need to remember, this is on the basis of what? Beta myelination. The more the myelinated the fiber will be, the faster the fiber will be. Simple understanding we need to keep. More the myelination, the faster the fiber will be. So more myelinated is going to have what? More conduction velocity. So you can appreciate this is the maximum diameter, this is having the maximum conduction velocity. This is minimum diameter, this is having the slowest conduction velocity. Like if you talk about fast pain, this is seen with the A delta. If you talk about the slow pain, this is C with the C fiber. And if you stimulate your A beta fiber, what will happen? Both these fibers are going to get inhibited, and now you will be having what? Now you will be having relief in the pain. That is the reason we are using what? A beta, massage, touch, pressure. This is going to cause what? Inhibition. For sometimes this is going to inhibit what? Fast and slow pain both. This is why, this is the reason, right? If they ask you maximum speed is seen with A alpha, slowest speed is seen with C fiber, maximum diameter, that is A alpha, slowest diameter is going to be C fiber, fast pain is going to be A delta, slow pain is going to be C fiber. So this is how they are asking question. You can answer this question, right? Okay, then we have got certain touch receptors. We have got Meissner's corpuscles that they are going to be maximally present in your lips and fingertips. They are responsible for low frequency vibrations like 5 to 50 hertz, you can remember, right? Whereas for low of high frequency vibration, you are having what? This Pacinian corpuscles are going to be responsible for high frequency vibrations like 60 to 150 or like 500 watts, right? Hertz. This is going to be what? Pacinian corpuscle. Then we have got the Merkel cell, responsible for what function? Very important. This is responsible for braille reading. Braille reading, and the blind people, they can read with the help of this particular Merkel cells, right? And Ruffini's are responsible for the joint capsules and skin stretch understanding with the Ruffini's. Very important, right? Now we have got certain pathways in our body. If I cut my spinal cord and present in front of you, you are going to find some fibers are going up and down. Let's try to understand how we are sensing the things, how we are feeling the things, whatever touch. For example, I'm going to pinch something here, how I'm going to understand this is happening. So we have got this corticospinal tract and we have got this spinothalamic tract. We have got two types of pathway. One is known as spinothalamic, one is known as spinothalamic, means from the spine to the thalamus. All the information from the spine is going to the thalamus. This is spinothalamic. Another one is from the brain, cortico. spinal. This is going to be from the brain to the spine. This is going to be descending tract. This is going to be ascending tract. We have got two types of wires going into the spinal cord, right? They are taking all the sensation, all the information to our brain, and from the brain all the information will be coming down itself, right? So let's try to understand what are the fibers we are having. So this is going to be the anterior side, this is going to be the lateral side, this is going to be the dorsal column, right? So in anterior column you have anterior spino, from the spine to the thalamus spinothalamic tract. You can have lateral spinothalamic tract, you can have dorsal spinothalamic tract. That means information can go to your brain via three pathways: anterior, lateral and dorsal. Whereas information can come to your from your brain to the lower part, that is going to be corticospinal via lateral pathway and anterior pathway. That's it. That's it what you need to remember. Let's try to understand this thing. So we can have what? Lateral spinothalamic tract, we can have anterior spinothalamic tract, we can have what? Dorsal column system. लात पड़ेगी तो क्या होगा? पेन और टेम्परेचर होगा. दैट इज व्हाट यू नीड टू रिमेंबर. सो लेटरल इज रेस्पॉन्सिबल फॉर व्हाट पर्पस? पेन एंड टेम्परेचर. Anti, you can remember anti touch, you can remember that is going to be what? Light crude touch and pressure will be there. This is going to be what? Crude touch and pressure along with sexual sensations. This is going to be what? This is going to be coming under which pathway? Under the anterior pathway. Anti, you can remember, right? And lastly we have got what? Dorsal column pathway, which is responsible for transferring two types of information. One is gracilis nucleus, another one is cuneatus. So how you are going to do the race? You are going to race from your legs, right? It is going to take information from your legs. Cuneatus is going to take eat is going to take information from your hands. This is going to take the information from your limbs, from your hands, right? Upper limbs, right? So this is how, what is the information? Fine touch, proprioception, 2-point discrimination, everything will be taken up in the dorsal column pathway. So let's try to understand. If someone is pinching in my finger, what is going to happen? How am I going to understand this thing? So this is going to be what? A pain sensation. And we already know pain and temperature is going to taken up by which pathway? This is going to be taken up by the lateral pathway. So this is going to be pain taken up by the lateral pathway. It will get cross over here. Every information will go to the thalamus. This thalamus will decide where to send this information. This is known as what? Relay station. This is known as relay station. So once this information will come here, it will decide, it will send to which part of the somatosensory cortex, right? So this information will go to the brain, right? And in brain you will be having this representation. This is going to be what? Sensory homunculus, right? Here you will understand which information is coming from where, right? And you will identify, okay, my finger, someone is pinching. How you will identify someone is pinching? Because you will be having pain. Now what kind of pain? What kind of pain you will understand with the help of fiber. What kind of pain? If it is taken up by the A delta, it is going to be what kind of pain? With a fast pain. If C fiber is taking it, it is going to become what kind of pain? Slow pain. So this is how your body will comprehend which fibers are taking the pain. Body will understand what kind of pain. Now what will happen? Now someone is pinching, that means fast pain is going to be there. It will go to my lateral pathway. From lateral pathway it will go to my thalamus, and now in thalamus it will send this information to my somatosensory cortex, where this is going to sensory homunculus, and now I will understand someone is pinching into my hand. Now I just need to do what? I need to take my hand back. So what my motor cortex will do? Now my motor cortex will start this information, and all this information from above can come into two pathways. Either it can go laterally, either it can go laterally here, either it can come here in the anterior pathway. This is what we have seen. It can go laterally, it can go anterior, right? And this crossing, decussation, or this crossing of corticospinal tract, this is your last exam question. Crossing occur at lower medulla oblongata. Need to remember, lower medulla is the location where you will be having the crossing of this corticospinal tract, right? All these fibers which are coming from brain till spinal cord, this yellow color thing, this is known as what? Upper motor neuron. Whereas from spinal anterior onset of spinal cord to the effector organ, this is going to be what? This is going to be lower motor neuron, right? So all this information will come here. It will come here. Which fibers? They are going to be motor fibers. Motor are going to be A alpha fibers, right? The mnemonic that we have discussed, prime minister. M for motor fibers. So they are going to be fastest fibers. And now what I'm going to do, I'm going to just retract my hand as soon as possible. All this information will come via two pathways. This crossing is going to take place at the level of lower medulla. Here you will be having 90% or 80 to 90% coming laterally, and 10 to 20% are coming in the anterior part. This is how we are assessing the information, whatever information is there, right? How we are assessing the information, how we are reacting to the information, and this is what they are asking, right? If they ask you question about upper motor neuron lesion, anytime you have problem with this upper motor neuron, what is going to happen? Upper motor neuron lesion will be having what kind of paralysis will be there? Spastic paralysis will be there. Everything will be increased, tone will be increased, power is not going to be there, tone will be increased, right? You will be having positive Babinski reflex is going to be coming out to be positive, right? Deep tendon reflexes are going to get increased, right? In LMN lesion, you will be having what kind of paralysis? Flaccid paralysis will be there. Tone of the patient will be decreased. Babinski is going to be what? Negative. DTR is also going to be what? Negative. So remember, in a lower motor neuron everything will be low, in upper motor neuron everything will be up. You can think like that. Okay, so this is how you can differentiate it between the paralysis also. Okay, now the next thing we are having is about the stretch reflexes. Now the stretch reflexes, you have to remember, we have got two types of reflexes. We have got stretch and we have got inverse stretch reflex. What are the pointers I'm giving you? You have to remember, this is going to solve all the questions, right? So stretch reflex, you need to remember what is the organ. That is going to be muscle spindle is going to be involved, right? Or what is going to be this what is going to be the thing you should be having? It is going to assess what? Muscle stretch. It is going to assess what? Muscle length also. So whenever there is length or stretch in the question, you have to mark the answer stretch reflex, right? It is a monosynaptic reflex. Alpha motor neuron is going to get activated. Ultimately you will be having what? Brisk contraction will be there. So always remember this contraction and this stretch reflex is going to be there. The organ is going to be what? This is the receptors are going to be what? Muscle spindle. Whereas in the inverse stretch reflex, what will happen? This is going to have what? Golgi tendon organ activation. Here you will be sensing what? Tension. It will be sensing length, it will be sensing the tension, right? Ultimate relaxation is going to happen. Ultimate is going to be what? Muscle relaxation. And here alpha motor neuron is going to get inhibited, right? This is going to be what? Polysynaptic reflex, right? So these are the things they will be writing you in the question. Muscle tension is involved, you have to think about inverse stretch reflex. Golgi tendon organ is involved, mark the answer inverse, right? The muscle spindle is involved, mark the answer stretch. Contraction is there, alpha motor neuron contraction is there, mark the answer stretch. Alpha motor neuron is inhibited is going to be what? Inverse stretch, right? Relaxation is going to be inverse stretch. Contraction is going to be stretch reflex. Like that you can answer. The next thing is about the aphasias. These aphasias are going to be seen in the cases of maybe stroke, maybe during some kind of trauma to the brain. This thing can happen, right? These are some areas we are having responsible for the understanding of the speech. Whatever things I'm telling you, you guys are able to hear through your ears. All this information going from external auditory canal, middle ear, inner ear, it will go. We have discussed all the pathways, right? And when it will go to your brain, it will go to which part of the brain? First thing, it will go to the sensory part of your brain, that is known as what? Wernicke's area, beta, right? This is going to be Wernicke's area, which is located in the superior temporal gyrus area number 22. Superior temporal gyrus will be there, right? And in this superior temporal gyrus, you will be having this sensory speech area, which is also known as what? Which is also known as understanding area, right? You will be understanding whatever I am speaking, you are able to understand. How? Because your Wernicke area is intact, area number 22 is intact. If you have lesion over there, what can happen? You are not able to understand, you will be having what? Understanding problem, right? And you will be having what kind of aphasia? This person will be having fluent aphasia. Now this information, whatever I am telling you, is going to get connected with the Broca's area. Broca's is for बोलना, है ना, speaking के लिए. It is responsible for the speaking, right? It is present where? In the frontal lobe. It is present in the inferior frontal gyrus, right? Broadman area number 44 and 45 also, right? This is 44, 45 is going to be there. This is a motor speech area for the word formation. Now whatever I'm telling you, you are able to hear. I ask you some question, you are able to hear through your ear, right? And this information is going to your brain via Wernicke's. Now you are able to understand what I'm telling you, right? If you can understand, and now if I ask you something and you need to answer, what should be there? Your Broca's should be intact, and now Broca's is going to be responsible for the production of speech, for the production of words, right? This is the motor speech area, right? If you have issues with the Broca's, what will happen? There will be problem with the speech output, right? And this is going to be what kind of aphasia? Here you will be having what? Non-fluent aphasia will be there, or this is going to be Broca's is going to have broken aphasias. This person is going to tell things, but they are going to be what? They are going to be meaningless things, right? He's not good, sorry, he is not able to speak the things, right? This is going to be the Broca's aphasia. He's not able to speak things, right? Now arcuate fasciculus is something which is going to connect your Wernicke's as well as your Broca's. Both the things are connected with the help of this particular thing, right? If you have lesion in this thing, you will be having what? Conduction aphasia. If I tell you something to repeat some statement and you are having what? Arcuate fasciculus problem, you are able to understand, but you are not able to comprehend between these two areas like Wernicke's and, so whatever you are hearing, all this information will be going to your Wernicke's. Then this thing is going to get connected with this particular area. Broca's and Wernicke's are connected with the help of what? They are connected with the help of this arcuate fasciculus. If you are having issues with the arcuate fasciculus, you are not able to understand what you are able to understand, but you are not able to repeat the same statement, right? I'm telling you, repeat anything, like you can repeat the any statement, right? Whatever statement, you can understand this particular thing, right? You can understand this particular thing, but if these two things are not connected, what can happen? You are not able to repeat the same statement, right? That means you can understand well, you can speak well, but you are not able to repeat the sentence because the area which is connecting these two is going to get damaged. And this type of aphasia is known as what? Conduction aphasia. Here there will be difficulty in repeating the words. Patient will be having difficulty in repeating the words. Angular gyrus can be getting affected, like this thing is responsible for the visual area. Sometimes we just read the lip sync also, right? So this visual area is going to connected with the speech. This is going to cause what kind of an aphasia? This is going to be anomic aphasia, right? Here the person is not able to pronounce the word after looking at it, right? This is going to be anomic aphasia, right? Now about the hypothalamus, very very important. Hypothalamus, you just need to remember 2 points you cannot skip. One is going to be what? Anterior hypothalamus. One is going to be what? Posterior part of the hypothalamus. Remember, just like a car, like a normal car, you can remember in a car what is going to be there? Anterior part is going to be what? Anterior will be normal car I'm talking about. Anterior part will be having what? Hot, because engine will be there in the anterior part, right? And posterior part will be what? Responsible for the cold thing, right? So you can simply remember, for all the hot phenomena, all environmental hot phenomena, who is going to be responsible? This is going to be your anterior hypothalamus. For all the cold phenomena, who is going to be responsible? Your posterior hypothalamus. If you ask me about like any example about thermoregulation, who is going to be responsible for these things? Anterior and posterior hypothalamus, right? We have got other hypothalamus lesions also, right? Other regions are also responsible, like suprachiasmatic is responsible for circadian rhythm, right? Preoptic nucleus is responsible for sleep and osmoregulation. Okay, lateral is responsible for your arousal, right? And this mammillary nucleus is responsible for the spatial memory, right? All the things are what are the things and where they are, right? Mammillary body is responsible for the learning and memory. So this is going to be a 3D structure. No need to remember everything, but yeah, most of the things you should be just go through these particular things once, and they will be there, right? This is going to be the very important thing you have to remember. You can also remember the mnemonic like SOAP, right? This supraoptic nucleus is responsible for the release of what? ADH, and this paraventricular nucleus is responsible for the release of what? Oxytocin, right? So these two things at least you can remember for the hypothalamus, right? What about this thalamus part, beta? Thalamus, ventro-posterolateral nucleus of the thalamus. Thalamus is also a 3D structure. This is also a 3D structure. Above this will be what? This is your hypothalamus. This area above this will be what? Thalamus, right? So this is going to be the VPL nucleus is the nucleus that is going to be somatosensory nucleus. That is going to be all the information that is going to go to your thalamus, all the information, somatosensory information, or you can say spinothalamic information. All the information from your body will go to your thalamus. Thalamus is the relay station. Relay station means now it will send the information to somatosensory or to any nuclei, wherever it needs to send. It will be the relay station. It will decide and it will send, right? Second one is your ventral anterior and ventrolateral. Ventro-posterior lateral we have seen. Ventro-anterior and ventrolateral is responsible for motor function. Your last exam question, they have asked this question, right? Anterior group of nuclei is responsible for what purpose? This is for the memory and emotion. Medial geniculate body, lateral geniculate body, old question. M for music, you can remember. M for music and L for light. So this is for the music pathway we have seen. For the auditory pathway, this is for the visual pathway, light pathway. All this information will come there, and then it will be traveling further, right? This is going to be the story of the nucleus that we are having, right? Now try to tell me the answer. Stretch reflex is due to what? Now if you have got the options like contraction is going to be there, muscle spindle is going to be there, what would be your answer? Golgi tendon organ, muscle spindle. So this is going to be what? Muscle spindle. Stretch reflex is muscle spindle. It will be having contraction. Alpha motor neuron will be activated. These things you have to remember. Just go through this once and it will be sorted. Simple question. Ventro-anterior and ventrolateral nuclei, that is responsible for what function? This is responsible for motor function, beta. Motor function, right? Decrease in speech output, like we have seen, medial geniculate body, lateral geniculate body. Medial is for music, lateral is for light. One is for the ventroposteromedial, that is for the sensory somatosensory cortex, and these two things are going to be what? These two things are going to be for the motor function. Decrease in speech output is seen in which aphasia? Speech output is decreased, that means bol nahi pa raha, that is going to be Broca's aphasia. Broca's aphasia. This is going to be a non-fluent type of aphasia. Non-fluent aphasia. Emotions are going to get generated where? Emotions are generated in the limbic system, and they are controlled by frontal lobe. They are controlled by the frontal lobe. Control of emotions is with the frontal lobe. Subthalamic nuclear lesion will lead to what? Subthalamic nuclear lesion will lead to hemibellismus. And now this question you have to answer. Hemibellismus, sudden contraction of a large joint, right? Shivering is controlled by, now shivering is going to be a cold or hot, right? In response to cold, right? So this is going to get controlled by which hypothalamus? This is going to be responsive to cold. This is going to get controlled by the posterior hypothalamus. Posterior hypothalamus. In response, anything is happening, sweating in response to hot. In response to hot, that means it is going to get controlled by the anterior hypothalamus, beta, anterior hypothalamus, right? So with this thing, we are done with the important things in physiology that you can see just before your examination. Remember guys, nobody can go back and start a new beginning, but anyone can start today and make a new ending. These are my Instagram, Telegram handles, right? You can appreciate, right? You can join me on Instagram, Telegram. If you have any issues before examination or even after examination, you can always connect with me. Thank you so much for all the patience. Keep learning guys, keep growing.